Welcome back. Thanks to the editing trickery, we are now back with the patient line back. And we've taken all the markings off because we're not needing those for injecting. That's just to teach you guys. And Amrit is going to start injecting now. So Amrit, which area are you going to start with and why that area first?
So generally I like to work top down, and
A lot of people do.
most of the volume loss is in this front area over here for Mark. It's kind of reposition things lower down as I plump or project.
It's going to pick things up.
That's it. Yeah. So think of it like if I have a little plunger, like a toilet plunger, a little suction cup, if I put it on here and pull the tissue out,
Yep.
that extra outward tissue or outward motion has to come from underneath. So something has to go up for it to come out.
Yep.
So it's going to kind of move things around. So I'm going to start here. I'm going to kind of do this mid face section over here.
Okay.
Then I'll come to the temple. Yeah. And then we'll start coming into lower face.
Sounds good.
Everything will be the structural stuff first. So
Okay, you're going to go deep down, trying to mimic bone.
Project everything off the bone, mimic the bone, replace the volume.
Yeah.
So that everything is being lifted off the bone.
Yeah.
And then the blending on the surface layer, we'll do at the end. Need a lot less.
I'll work in exactly the same way. Yeah.
Perfect. Right. So Mark, I'm using those little fancy Japanese needles. So super tiny. I'll let you close your eyes so you don't see the needles coming around. And then I'll just bring your chin up a tad. That's it. Just like that. You'll just feel my fingers moving around a lot. And then you'll just feel a little bit of pressure as we start to do these injections. But I'll talk you through it the whole time. Okay, right. So I'm just starting at the front of the cheek again.
So this is the anterior cheek that Amrit is doing. And there's a reason he's not going even closer to the nose. The reason is if the needle is a little bit closer to the nose and more towards the midline of the face, then you have a risk of hurting some important structures that are there. So you've got something called the infraorbital foramen. This is where you get the infraorbital nerve that exits. And if the needle is much closer towards the midline, you could hit that nerve and damage it. So what he's done is he's entered slightly further away from that foramen where the nerve is for safety reasons. But if you look very carefully, his syringe is actually angled towards the middle of the face rather than to the back of the head. So he can get the filler to almost sort of travel to where he wants it to go while maintaining safety of not actually hitting any important structures with the needle. And he's injecting very, very slowly. You don't need to go quickly. How's it feeling? Are you feeling a lot of pressure?
No, so the distance to the bone was very short as expected.
Yeah.
And so I went in at quite a shallow angle so I can kind of have the majority of the filler projecting outwards.
Sure.
If I went 90 degrees, the filler would then track around in other directions.
Yeah, you don't know where a trough is squashed out. That's it.
Yeah. So, and just with that first bolus alone, I can kind of see
I can see straight away.
It's really lifted out quite nicely.
Yeah. And what kind of volume have you used there so far?
In this first injection, just 0.3.
Okay.
Yeah, so just a very controlled amount in that first front of the cheek over here. It's already improved the lid-cheek junction.
Yeah, absolutely.
Yeah. So the blending on in here is minimal.
Yeah.
Because the superficial fillers are softer, thinner, more runnier. Near the surface of the skin, it's harder to disguise or hide the filler as well.
Yeah.
So you run all the problems of potential migration, Tyndall effect, or seeing the discoloration or the blueness of the filler, seeing lumps and bumps near the surface of the skin. So and it won't last as long because it's nearer the surface, more muscle abuse from that filler as well.
Yeah.
So I'm just trying to minimize what I need on the surface, and if I can get away with using none on the surface, that would be the greatest thing.
Yeah, that's the ideal.
So we're just going to go around and add a few more injections in. So the front of the cheekbone and the side of the cheekbone are now almost talking together. We're kind of going into the inferior aspect where the deep cheek fat runs just below now.
Yep.
I want to kind of volumize that area so we can kind of then start working on the buccal area down the line as well.
So when Amrit says he's trying to make sure the inferior area is also treated, inferior in typical English means something not as good, but in anatomy, inferior means below and superior means above. So that's all he's talking about. So superior in this case means closer to the top of the head and inferior means closer to the feet. So he's just gone slightly inferior and a little bit more lateral to the side of where he's gone. But he's also kept quite a shallow angle. He's not attempted to go at 90 degrees like this. And he's still facing the syringe actually more towards the middle of the face than straight towards the back of the head as well. And that looks like you've injected another 0.3. Would that be fair to say?
Yeah, that was it. Yeah. So now we're pretty much at half a syringe into that area there now.
Yeah.
So those two injections, kind of all periosteal, all the high density filler.
Yeah.
The way I see is that the zygoma, the outer cheekbone, and the maxilla, the inner cheekbone, where they meet, they're almost think like there's two tectonic plates, and they have like a little bit of a fusion line between them. And I've kept all of the filler running just along that front maxillary bone here, which is kind of caved in.
Yep.
To then replicate that anterior cheek padding there for Mark.
Okay.
It's now given us a strong front of the cheek, a strong side of the cheek that we already had.
Especially compared to this side.
Exactly. Yeah.
Which we'll show you guys in a second.
But it's starting to highlight the areas below that are quite gaunt now, isn't it? Because we're fixing one area, the other area becomes more apparent. It's just a whole play of light reflexes, shadows, and brightness.
Mark, how did those first 2 injections feel?
Oh, I didn't feel them.
Okay, you didn't feel them. So that's pretty good. So we've had numbing cream on. He's been sat with cream. We put cream on 2 times.
2 times, yeah.
15 was in total. Yeah.
Yeah, with 10% as well. Strong cream.
Quite strong cream. And this filler that we're using today actually has anesthetic in there as well. So it's very comfortable as he's not screaming, as you can tell, which is always a good sign. So you carry on.
Yeah.
Do whatever you wish next. And what are you going to go for next?
So next, I want to keep with the maxillary bone. I'm going to go into the nasolabial fold.
Okay.
Mark doesn't have a very deep fold.
Yeah.
But he has a bit of a deep piriform fossa at the top of the fold. So I'm going to go in and replace volume there.
So what Amrit is doing is he's going for what we call the piriform fossa, which may be a little bit difficult to see on camera. But essentially he is going right here. If you can see, it's essentially the corner of the nose. And that is called anatomically the piriform fossa, the space underneath. And if you put your finger and push down where the side of the nose is, you will feel the bone above the teeth. That's the maxilla bone. So what he's trying to do is bring that depth at the corner of the nose upwards, more close to the surface, more superficial, instead of being an area that's quite deep. And I noticed that you injected very similar to me in that area. You are, instead of going, let's take this pen as an example. Let's pretend this is the needle. Instead of going flat down like this or like this, you're actually angling like that and like that. Now, I know why you do it, but if you could explain to the viewers why you do that.
Yeah. So if I was to think of it as that if the needle has a hole, so on one side of the needle, if I'm at 90 degrees, whichever direction the hole of the needle is facing, that's the direction the filler will track. So I can see where the hole of the needle is and I can go in at 90 degrees, but the filler will then track along under the skin in one direction. But actually what I want to do is I want to project a very narrow, specific pinpoint area up and out. So I want the filler to be projecting the skin this way. So I want the whole of the needle this way. So if I go at a shallow angle with the hole facing up towards the skin, as I start to then push the plunger, the filler comes out, the skin is then projected upwards by the filler. And then I need a lot less filler. So then I'm not worried about long-term migration from overfilling.
This is to do with it, not just getting it in the right position, but also efficiency.
Yeah.
If someone injects your face and they're going completely vertical like this or like this, and the filler comes out on the side in the wrong place, they're then going to have to put more filler in.
To hide the bad filler.
Exactly.
Yeah.
So this is right position and also an ability to restrict from using too much volume.
That's it. Yeah. So I always kind of use this approach where the depth, plane of placement is really important.
Yeah.
The product, the thickness and the projectability of that product is really important, which is then all the fancy characteristics of the gel.
Yeah.
And then it comes down to the direction that the filler is coming out into the tissues as well, makes a big difference as well.
Absolutely.
So all of those things combined can then make the difference between a really, really high level result and an average result.
Correct. And just so people know, if you ever have filler in this area where it's just injected, which is here, the base of the nose, sometimes your top lid goes a bit funny. And I know the reason.
Yeah.
You're the star of the show. You tell us what the reason is.
So actually just from the infraorbital foramen, there's a bundle of vessels, veins and arteries and nerves that come out, but there is a nerve that then runs along just through that little area down to the upper lip, supplying sensation to the upper lip. So the anesthetic in the filler kind of numbs that area. The nerve then doesn't really supply the area as well because it's gone to sleep. So this area kind of also goes to sleep sensation wise for a bit, but it comes back in about a couple of hours.
Yeah, absolutely. So where you've got a little bit left, you'd say what?
Yes, so on the third end,
something like that.
Yeah, it's got 0.1 of it. Yeah.
And what are you thinking?
So now I'm kind of just looking at how it's projected out. So I can kind of see I don't need any more in the piriform fossa. I don't really need any more in the anterior cheek. The area that's really missing it now is the buccal area, but I can't. There's no bone there to reach and contact to project off.
So this is the wrong filler for that.
That's right. Yeah. So I know I'm going to need a cannula for that as well. So I'm going to skip that part now.
Yep.
Now looking at the temple, we'll go ahead and do this with what I have left before we can carry on. With more. Good, right. So if I just turn Mark off to the side, that's perfect. How's our feet, Mark? Nice and comfortable? Not too bad so far?
Fine.
Oh, lovely. Right, so we want to kind of go into this area. We want to go at the bony layer first. So we'll do a nice deep breath in here, Mark, and just a little bit of a scratch here.
So when Amaranth's injecting, he's going through a muscle called the temporalis. If you were to clench your teeth very hard, typically what people do is they feel the muscle on the jawline here. But actually, if you feel your temple, you'll feel that contracting as well. So he's going through that. So it's important the patient is nice and relaxed and that muscle is not contracting. And he's placing the filler actually underneath that muscle, really quite deep, as deep as he can with that needle. You're aiming for periosteum there, right?
Yeah.
And periosteum is the layer that supplies the bone. It's overlying it. Some people say I'm placing it on the bone, I'm placing it on the periosteum. We're referring to the same thing as far as the injection is happening. So you've got a brand new syringe. This is syringe number 2.
So that was a very small amount I had there. So I know I need a large amount of this area, but it's already started working. So
yeah,
I'm going to go in and add a little bit more in this area.
Yep.
And then I'll go into the next structural area, which will be the chin and the jawline area before we then swap to cannula.
Sure.
Okay, so just same injection again. Now this area is where we have the external carotid artery coming up and giving off the temporal branches. We have a deep one and a superficial one.
Yep.
So I'm being quite mindful of lots of vasculature in this area and just kind of being respectful of the anatomy to then add the filler in the volume we know we need safely as I can into that area with the anatomy that Mark has presented with.
So the carotid artery, when it comes up into the neck, it splits off into branches. Well, lots of vessels split off into branches. And what Amaranth is saying, when it comes to the temple, we have some of those branches. One of them you can actually feel. Sometimes you can see a vessel pulsating on the side of your temple here. That's a superficial temporal artery. But there's one that you can't see visually, which is the deep temporal artery. And that's what he's got to try and avoid in this area. And there is an area where if you put your needle in that particular position, there is a lower likelihood, based on anatomical studies and cadaver studies, that you're going to get it in that danger zone where that vessel is, which is why he's very careful as to the 2-dimensional position on the skin of where he pushes the needle. And to make it comfortable, that's why he's actually injecting really quite slowly. So far, as I can see, he's done roughly 0.5 ml in this single region here. And I think what's nice about this particular technique is that you can actually, when you go underneath the muscle and you push the muscle up, you're actually pushing up connective tissue, which is why the eyebrow can have a little bit of a lift in this area if you use it with this technique. So what are you thinking after you've injected that? How does that look?
It's worked really well. So the zygoma, the outer cheekbone now, and the frontal bone, the transition, the one thing we've got to be careful is to over-volumize this area to give Mark a light bulb effect. I don't want him to look like a peanut at the top. So we want to soften the depth of the hollow, but we don't want him to then overtake the cheek or the forehead around it. So it's now...
That's our limit, if you like, isn't it?
Basically, yeah. So now when I look over the top, which will, at some point we'll find a camera angle to show one side versus the other, I can see that this is really nicely projected out. This is now looking dramatically hollow, which having replaced the volume on this side has disappeared. And then we probably had about 1 millimeter or so in brow positioning, slightly a bit of a benefit like you described. So that's been like a nice bonus.
Yeah.
So next stage we'll come on to is chin, pre-jowl, and the gonial angle. And then that will kind of allow us to then just improve the projection on these areas.
Yeah.
And then it's just all the blending where we can't go to bone.
Yeah, absolutely. So when Amaranth said gonial angle there, what he means is the jaw angle, if you like, the back of the jaw. And he's using the same filler. This is filler is going to go onto the periosteum or onto the bone, whatever your phrasing choice is. And we'll see where he decides to treat first in this area. So he's going to the front, he's going to the anterior region, and he's going to go to the chin area. And men in this area, they have a little bit more of structure in terms of the corners of the chin. Whereas in women, it's a little bit more smooth and rounded as you go from one side of the face to the other. So what he's doing is trying to create a little bit of that structure and definition into that region. And correct me if I'm wrong, Amarit, but you are also trying to make contact with the bone in this region and project the skin off the bone.
That's it. Yeah. So there's a little bit of chin recession, which happens naturally as we get older. The mentum or the bone in the chin actually is one of the bones that really resorb as we get older, which then accentuates the jowls around it. So it's a case of then just bringing back what bone or positioning of the bone, the structure that Mark had maybe 10, 15 years ago. And the natural bony recession is just kind of an area where the chin then starts looking quite dimpled. You start getting the pebbling on the chin over time. The muscle starts becoming hyperactive. Some people genetically have a recessed chin anyway, and it's nothing to do with aging. It's just they're born with a weak chin, and they have that hypercontractile state where the mentalis muscle is kind of then giving them that. Every time they close their lip, it's scrunching up their chin. They have lots of pebbling and stuff, and you can do Botox to weaken that, but if it's a structural issue, Botox is masking the problem or making it harder for them to close their mouth together. So if anything, repositioning the structure behind it, and then the muscle has to follow that. It's kind of what you said in the temple. It stretches everything out, makes it sit better, has a cosmetic advantage and a skin advantage.
Completely agree.
Good, right, okay. So, sorry, Mark, that's for the first really sharp injection you felt so far. The bone there is very sensitive compared to the bones we've worked on so far. But the first injection has added some numbing in, so you won't feel as much on this next one. We've just got one more to do here as well anyway.
Can I ask how much you used there roughly?
0.25.
Okay.
Yeah, I'm going to use another 0.15, 0.2. Should be just roughly about half a syringe in that one angle there.
Okay.
And that'll be the one side. We're going to focus on just completing one side so we can get a bit of a side-by-side comparison as to how it's looking.
So you've gone, in terms of your needle placement here, you've gone slightly inferior to your previous point.
Yeah.
And I guess what you're trying to do is join up the different parts of the chin together.
That's it, yeah. And I kind of just want to leave a little bit on the exit over here, just
a bit of projection.
Just for a bit of projection on the skin. That's all. There we go. Good. Okay. So if I bring Mark in the middle now, we can kind of see we have a bit more of an outwards and a squarer edge of the chin on this side and a softer side that side.
Yeah.
We've accentuated the dimple in the middle, which we can soften as we start to do the other side anyway.
Yeah.
But I'm going to continue now along the jawline itself, the mandible.
Okay. So now you've got syringe number 3. Where are you going to start using this syringe first?
So we've filled up here, filled up just as far underneath as I can go for the deep cheek fat. Soften the piriform fossa of the nose to mouth area. So that's all looking well projected. So now it's this kind of lower face area, the area between the upper teeth and the lower teeth. That's kind of the sunken in area. Once we reframe that with a little bit of the jawline angle. Maybe some pre-gel. I'll see how that looks in a moment. If it needs any there. And then all the blending work in between the skin over here with granular. That will be this side done and looking dramatically rejuvenated.
Definitely.
Just from the volume effects. Like we have had the hyaluronic acid of the filler do its job in the skin. It's not, even the process of us delivering that in will activate some fibroblasts. There'll be some positive benefits from all that collagen production and these other things eventually in a couple of weeks. But just the volumization, the mimicking the bone, the projecting the tissues, that alone would have had quite a nice effect. In this few moments that we've been working with Mark.
So syringe number 3.
So Mark, let me just turn you off to the side over here. We're going to go at the back of the jawline here. If I get your chin up a little bit, that's good. If you just bite together for me for a second, that's it. And then you can relax. That's perfect. Okay. So I'm going to close your mouth for a moment. That's it. But you can relax your teeth.
So by getting Mark to turn the other way, what Amrit's achieved is a little bit of a stretching of the skin. And when it's stretched over the jawline, it's easier to actually see exactly where the bone is. And when we get the patient to clench, it's easier to palpate with our finger where the edge of the bone is because we feel that clenching muscle, which is called the masseter. And another benefit, which we're going to see here, Amrit's already treated the chin just now, and now he's going to the very back of the jaw, the opposite ends. And when you volumize both those areas, one effect that you get is you get this almost kind of stretching effect. And the skin in between those two areas can sometimes look a lot straighter in the jawline area as well. So now he's staying on that jaw angle and he's trying to make sure that the filler is on the bone, if possible, and underneath that clenching muscle, that masseter muscle. And it can be a little bit of a sensitive area.
And so it should starting to be taking over now, so it should be quite comfortable for Mark, but it's just that initial pressure on the bone is what they usually just for a second. But I think like a hammock, the jawline is the hammock. You can get a jowl in the middle. But if I move the two posts of the hammock back,
you stretch it up.
You stretch up
with analogy.
Yeah.
I think sometimes the jump that patients feel is because they're just not expecting it as well.
That's it. Yeah.
It's I think unusual. I've never had fillers before.
That's it. Yeah.
How do you feel comfortable injecting that area in terms of the layers? Because I think some people struggle to make sure the filler is underneath the muscle.
I agree.
What do you do? What steps do you take to ensure that your filler is in the correct layer? And
So first of all, like you said, just positioning the patient so that I can kind of see under the neck on the side of the ramus. Feeling both. So I can feel the back of the jawbone, the front of the jawbone, the mandible, ramus, feel where they merge together. Then I had Mark clench his teeth so I could kind of see where the masseter muscle was kind of bulging or projecting. So I kind of know I don't want to be just on the bone itself,
Mhm.
because then I can have potentially the filler over time slide down into the neck
Mhm.
or other areas. So I kind of want it to be, I want to use the attachment boundaries of the muscle, the masseter muscle, where it'll attach to the back, there'll be a connective tissue, it'll attach to the bottom, there'll be connective tissue. So I want the filler to sit in front of the connective tissue over here. So once I've felt the muscle, I've found the boundaries of the muscle,
Mhm.
I can then just place it just in front. So I know I'm in this little triangle in front here.
Like a little pouch.
Yeah, that's it. And the muscle above it will keep the filler buried under it. The bone below the muscle will keep the filler squashed between. It basically sandwiches the muscle and the bone and the filler in between.
And that's why you come from slightly behind as you inject instead of
Rather than direct. Yeah, so as I've kind of come in, I've had the filler then with the bevel up. So the filler's then sat beautifully in that pouch, project this angle out.
Yeah.
I haven't had to use much. I've only used 0.3 and a bit.
0.3 mil.
So that's just giving me a really nice projection of that angle. We still don't want this to then overtake the lateral cheek. We want it from then in line with the lateral cheek at most, rather than overtaking it, because then it just gets too strong. But yeah, then it was just very much a case of, rather than measuring a set amount, just watching it change, because it just inflates in front of you. Yeah.
And I think this is an important point. A lot of patients say, well, how much volume do I need? We have no idea.
Yeah.
Until the needle goes in, it's absolutely impossible to know. And when the needle goes in and we start injecting and we see the skin move, and then when it's in the right position, we stop, that's how much you need.
So looking at a car's tire.
Yeah.
I don't know the PSI, how much more air I need to put in the tire until I connect it and do it.
Yeah.
I have a rough guide. I can from experience, I can know if I look at a car, it's basically flat.
Yes.
Or it's or it's really bulging. I kind of know it needs a little bit or a lot, but I won't be able to then really know exactly how much each point needs. So I'll always then say to a patient, it'll be between this and this in terms of mil, quantity wise.
Yeah.
But I always want to use the least. My goal is not to make money and not to profit. My goal is to get the best outcome with the least amount possible.
Yeah.
But that's why I'd always use a range. And if I can be on the bottom end of the range, even
Always
better.
Yeah.
But if I do need a little bit more to get a better result, then I will explain to the patient, well, we've done this here. This is what it looks like. Can we go a little bit further? And generally patients are like, well, yeah, they're blown away. They want to do it.
Yeah.
So, yeah.
Sounds good. So only 0.3 used?
Yeah. So we'd go in and do a tiny bit in the pre-gel, and then we're basically ready for cannula work.
Yep.
Yeah.
So when Amrit says pre-gel, I'm sure you know what a gel is, the bit that hangs off here. Pre and post gel are just different sides of that along the jawline. So he's gonna try and add some filler into the periosteal. Is it periosteal layer you're going to? Yeah. So the bony layer as deep as possible. And this is again, it's going to stretch that hammock out to make sure the jawline is as straight as possible and as smooth as possible from the front to the back. So again, he's got a bit of an angle. He's not going perpendicular like this. He's going upwards very slightly and angling everything so that he can have control over which direction the filler exits the needle and then positions itself in the actual patient as well. And I think actually this is not easy based on the fact that you're actually using a very small needle, aren't you?
Yeah. So
normally we get a bigger needle. I'm sure it is here with the actual pack of the filler. Amrit's specifically chosen to ignore that needle and go with an even smaller one, a smaller gauge, which is a little bit more comfortable for the patient, but it does necessitate you have to inject slow because of
the pressure, the extrusion force, how hard I have to push with my thumb on the plunger to actually get the filler, which is a very thick, stiff filler
for sure.
Which is great for doing what we want inside the face, but it doesn't exit as easily. But for me, I get a bit more precision, a bit more control, more comfort for the patient. And if you've had a look, we've done all these injections, we've not bled.
Yeah.
Which is, for me, to then be able to see the result without bruising and swelling. And for the patient's downtime, the smaller needle holes will close up quicker.
Yeah.
So I'll get a better finish, and I can see the finish before the swelling sets in. So I just prefer these needles now. My thumb's gotten stronger.
So we've got the last syringe here. This is syringe number 4, is that correct? For this particular side. And the first thing I've noticed, and the thing that everyone else can notice, that's a very long instrument attached to a needle, but that is to the syringe, sorry. But that's not a needle. That is a cannula. If you could, Amrit, just hold that in front of Mark's face, so we can see that on camera. There we go. So, and if you could just put your glove behind as well, that's it. So we can just see that. Perfect. So that's not a needle. That is a cannula. So if we were to take that and just gently touch the skin, it wouldn't actually pierce through because it's rounded. And the exit hole is not on the end. It's on the side. Right?
Yeah. So there's a little triangular mark on the hub, so I can see where the port exit will be from that. Yeah,
exactly. So you go ahead.
yeah, absolutely. So
I'll speak to you as you go.
this is the first time we've swapped from the thicker high density filler that's all been going onto the bony or the periosteal layer with a needle to now us going just under the skin into the first layer of fatty tissue with a cannula. And I'm also using a much softer filler. So this is the opposite end of the spectrum. This is about as soft and thin as fillers can get.
Yeah.
And it's going into an area where the skin is super thin, super delicate. So hiding filler under this really thin layer of eyelid skin is difficult. I wouldn't be able to hide a thicker glue-like filler under here very easily. It would just look lumpy, bumpy, prominent, wouldn't settle in. So I'm going for the softer filler. I'm only going to need a small amount. This is going to be a tiny amount in the eyelid here. We'll use the rest of this in the other side over here and the around perioral area later.
Yeah.
And then we'll go to a more medium filler for the cannula over here. But the cannula is going to allow me to go into an area where if I was to try to cover an area this close to the eyelid with needles or these other areas, around the eyelid, I was given a black eye, a lot of bruising. I wouldn't be able to see the results. This would just be a bit more atraumatic, less trauma, less bleeding, less bruising, more comfortable mark as well.
Yep.
But like you said, it's blunt. It can't make an entry into the skin, which is good. It means it won't do any cutting inside the skin either.
Yep.
But it comes with its own little introducer needle, so I can make a hole over here.
I'm going to be an assistant here.
Oh,
and hold this. So what Amrit's doing is holding the cannula above the skin so he can see how far it reaches. And based on how far it reaches, he knows where to enter. This is a needle he's using. Technically, you can inject with this if you want. But the needle is going in just to make an entry hole in the skin. And in a second, he's going to then bring that back out. There we go. And he can pop this in here, held up by his glamorous assistant. So now that hole is there, this cannula can now enter. That hole is just slightly bigger than a cannula for obvious reasons. So this can go in. And sometimes there's a bit of a faff trying to find the hole that you just made because it is quite small, but we've found it in true Blue Peter fashion. A good time here. So what he's trying to do is make sure that as soon as he enters, he is able to reach the layer that he would like. A needle can just go through any layer because it's incredibly sharp. And that's why it's useful when you want to, get down quite deep and make contact with the bone, because it will just pierce everything. It's soft. A cannula, unfortunately, to go through layers vertically is very difficult because it's not sharp. It's very, very blunt. However, it's very easy for it to go along a layer without going above or below that particular layer. And so what he's trying to do now is just ensure that he's in that correct layer, and he will feel resistance. He'll feel tension. And based on what he's feeling, he will know, okay, I'm probably touching this ligament over here. I'm going to come back. Or I know this is a little bit bouncy, but I think I can pop through. So that's probably the muscle. So if I break through that, I know the layer I want is underneath the muscle. So I've got to pop through this resistance and then go through. And it might sound traumatic to some of you, but actually it's really not. It's perfectly fine. And everything will recover very, very nicely afterwards. So he's got, I think that's probably a 50 millimeter cannula, and he's nodding. And most of that cannula now is inside the skin. So, and there's a little bit leading outside. So he's probably in the skin about 45 millimeters from the point of entry to where the end is. And what he's doing now is just gently pressing the plunger very, very gently. So just a tiny, tiny trickle. And he's keeping the cannula moving if possible, so it doesn't all end up coming out in one particular place, which is important here because you want to spread this like butter on bread, butter on toast, nice and smooth, which is why he's trying to keep everything moving so there's not too much in one particular place. How's that feeling? Is it feeling nice and smooth? There's
a bit of resistance getting in initially.
Yeah.
Mark's connective tissue is really strong. It's
good.
Not as easy to get through, which is good. But once I got through it, then like you mentioned, the cannula was in the right tissue plane, so it just glided in very beautifully.
Yeah.
I was able to then follow the ligaments around the eyelid.
Yeah.
And then just start filling gradually. And just now it's a game of how patient are you? All the other areas we fill so rapidly. This is the area where we need the most patience as an injector, not just rush it, especially when psychologically a patient's a bit nervous because there's this thing under their eyelid, and Mark's probably just feeling movement, not sharp pain or discomfort really right now. How is it for you, Mark, right now?
It's fine.
Yeah, it's fine. I think also people look at this, and I'm sure some people are watching this thinking, on the close-up shot thinking, oh, that looks really painful. It's actually not.
It's actually very comfortable, surprisingly comfortable.
Because it's near your eye, you automatically take a big, sharp breath in. But actually, there's no absolute major blood vessels here, like the facial artery, the angular artery, anything like that. And you're not really going to be hitting anything, hitting any nerves in the needle, because we've got a cannula here, and the nerve here, the infraorbital nerve, is going to be quite deep down. So actually, it's a very, safe area to inject, especially if you're doing it with a cannula as well. So it's only visually something that looks pretty scary or, difficult to go through. But for a practitioner to do, it's actually, it can be difficult. But for the patient, actually, it's very, very comfortable. And this is more comfortable than, say, lips or something along those lines.
That's it. And I think it's really interesting that you say that, as a practitioner, this is probably the most technically challenging area to treat, because it's not forgiving at all.
Yeah.
And the anatomy is quite complex. There's so many ligaments and connective tissue over here.
Yeah.
You're basically trying to merge the cheek and the eyelid back together without making the eyelid look puffy, without using too much filler, which would be hydrophilic and draw water into it and add more volume.
Yeah.
So it's an area which takes a lot of practice and experience to do, which is why I see a lot of patients on a weekly basis that come to me for eyelid rejuvenation that need this approach with a bit of anterior cheek and a bit of under eye filler, or this kind of approach that we're doing for Mark. But they've been misled by the clinic and the practitioner because it's so technically difficult.
Yeah.
Much easier for them to push 3 or 4 sessions of, Lumi-Eyes or skin boosting to the eyelid, where yes, the eyelid skin becomes more lax more quickly because you have such thin skin there in the first place. You don't need to thin the skin out much before it starts looking wrinkly and crinkly compared to the cheeks or the jawline, for example, where the skin's thicker. But generally, for a lot of patients, it is a volume deficit that they're seeing and they're complaining of, and the skin is not actually that problematic.
And I think in this particular area, one reason that Amrit is able to use a relatively speaking small amount of volume in this area now that he's doing is because he did the injection onto the bone first. So he did the anterior cheek. That was the first injection we started with, actually, where he pointed it slightly upwards to direct the filler. When you do that and you project the anterior cheek, automatically that improves the appearance of the under eye area. And we did this in the examination part of this video as well, where he put his finger into the face and he saw the area above come up slightly and improve the appearance of that. So this is something that we call a sort of combination treatment. So the anterior cheek and tear trough. This is what we call a false tear trough, where the appearance of the under eye is exacerbated by the front of the cheek. Sometimes the front of the cheek is fine, and it is truly just the under eye on its own, and that's what we call a true tear trough. And what we're also going to do after we finish this, we're going to send Mark on his way, and we're going to record a bit of a podcast episode here in the clinic as well on location. And we're going to discuss these things in that podcast episode. So this video will probably come out first, so keep an eye out for the podcast episode. If you've got any particular questions for Amrit, either comment them down here or underneath that video, and then maybe one day I can put your questions to him on the Zoom call or something, and we can pop that on the channel for you as well. Now, I'm stood from behind, and I've got the advantage of being on this side of the table, where I can see the untreated side very clearly and the treated side, and it's a dramatic difference in terms of youthfulness and youthful volume. And when we finish this side, the left side, we'll sit Mark up and you can see a half and half on the camera as well. But that's looking brilliant. That's looking so smooth.
Yeah. And we're going to 0.15.
0.15.
That's about muscle it needs.
This is in real time. And in all that time, he's only injected 0.15. Now you get an idea of just how little pressure he's putting on that syringe. Barely any, in fact, like less than a drop. All of that time, that was probably 5 minutes worth, and he's done 0.15. Compare that to when we were treating areas in the bone where, maybe in 30 seconds we've injected 0.3, 0.5 mil. Big difference. And one of the reasons is, as Amrit said previously, the skin is so thin in this region. If you put too much in one go, you'll see it straight away because it will just poke through. You take it nice and slow, you keep everything moving, you spread it like butter on toast. It's going to be much smoother, which is really crucial. So that's looking great.
Just these purple bits left, to finish, yeah.
So now you're going to treat everywhere kind of underneath that we've had marked out. So we're going to go for the cheek area, which we call the buccal area. It's spelled B-U-C-C-A-L, if you want to Google the anatomy at all. And we're going to go with a cannula again. And really, once again, just spread everything like we're spreading butter on toast. And you see the triangles that Amrit's done. He's done these triangles because the triangles represent the direction of his cannula. So it represents where he's going to enter the skin and actually move his cannula. You probably hear him opening the boxes. He's getting the other fillers ready right now. And this is real time. It is not edited, as you can see. So he would enter from one particular part of the triangle and then fan. It's called a fanning technique in dermal filler terms. And then fan all these areas. And then we might even do a bit of a massage after to just blend everything in. Now, in the lower face, the reason we want to be relatively superficial, relatively close to the skin surface is because all over the face, there are important structures that we don't want to hit. Structures which can be damaged. In the lower face, kind of, let's roughly say, the cheekbone downwards, most of these important structures like nerves, for instance, they are below the midpoint between the skin and the bone. The midpoint between the skin and the bone, roughly speaking, is what we call the SMAS, which is connective tissue, allows your face to move as one instead of all separate units. Below that SMAS, or deep to the SMAS, is where all these important structures are. So by staying above that, we stay nice and safe. Earlier in this video, you saw Amrit say that there's a lot of variation in the direction that vessels take in everyone's face, and you can see it on ultrasound. But what it doesn't vary, unless you've had surgery, is the layer. So one vessel might go right then left on someone else might go left and right. But the layer is always the same. The depth is always the same. So when you have thread lifts, for instance, in that lower face, all the threads need to be just under the skin because the things that could be damaged are deep to that SMAS and a little bit deeper down. So our cannula here is going to be superficial or above that SMAS, that connective tissue layer, which is halfway between the skin and the bone, roughly speaking. And so this is why it's important to keep the cannula moving and make sure you don't stop in one place. It will just poke through. And I think he's getting a much thinner filler here, which is going to be much more runny, if you like, or less viscous in proper terms.
More in the middle now, and not the bony stuff, not the thin stuff. Just in the middle now. Goldilocks filler, I call it. So let me just start by going into the buccal area, because this is the main kind of thing that we're seeing now. So if I just turn Mark this way. Now, it's quite rare to get this kind of level of buccal volume loss. Mark's got a lot of volume loss.
And it's really quite specific as well. It's not generalized.
That's it, yeah. To the point where it's kind of caused a crease, a deeper groove in the skin almost, Mark noticed. This side is actually a little bit more prominent than the other side. So I need to kind of make sure that I always treat it like a hill and a valley. Here's my hill. Here's my hill, and I've got the valley in the middle. So I've got to make sure I'm really careful with my placement on the filler. Because if it ends up over here, I'm only doing myself a disservice. I need more again next to it.
And I think it's fair to say you're probably going to use more on this side than the other side. Because this is a bit
more together.
So yet again, what he's doing, he's working out how far his cannula needs to reach in the skin, which is this tip, and looking at where the cannula's base is. That's where he's now going to enter with that entry needle. And I'll put this here so we can dispose of that when he's ready.
Just a nice deep breath here, Mark.
I know there is colour on the skin, but this has been disinfected.
Oh yeah.
Before you start commenting, I'm sure there'll be some jobs worth.
Chlorhexidine on everything.
So his hands are going to be just slightly stretching the skin in the way that he wants, so that it's easy for the cannula to go in and dive when it's just under the skin, and then flatten out so it can stay in that layer. There we go. So you probably saw him cannula pointing deep and then resting parallel to the skin to go forward. And you should hopefully see that in the close-up shot there, the way it traveled forward. There we go. And by lifting the skin, you can see exactly where the cannula is, but also he has another ability. By just lifting the skin like that, if you can see the edge of the cannula incredibly sharply, it's way too superficial. If you can't see the outline of the cannula at all in any way, probably way too deep. And that's where the important damageable structures are in this area. So by getting a rough outline of the cannula, he can say, okay, I'm in the right layer. I'm in the superficial fat layer above the SMAS in this particular region. And sometimes what's nice is, before you've even injected, you can see the cannula in the skin there, just a cannula's presence mimics volume. So you can kind of tell, does this look good before I even release the filler? How's that feeling, Amrit? Describe that feeling to viewers who maybe haven't injected.
Yeah, absolutely. Really easy. The cannula went in, a little bit of resistance that I got through the skin. And as you mentioned, on one side was between the skin and then the muscle or SMAS layer below. I wanted to flatten out. I flattened out. It smoothly glide it all the way along. There's a few little connective tissue fibers or cutaneous fibers between that layer.
Yep.
So you get these little micro little pops or gives as you kind of go through that. And you can see the skin on the surface starts puckering together.
Yeah.
And then you get a loss of resistance as you go through the layer. So I pretty much run it all the way up to the fissure along the here where the groove runs up to, and then just started to just smoothly layer the filler in.
Yeah.
I kind of dumped it into like lots of blobs. So then as it heals, it stays kind of
separated.
Yeah. So I want it to just be a seamless river of filler or a blanket of filler under the skin. Yeah.
And Mark, as you're lying there, is this painful?
No, it's all the odd sharp scratch.
Okay. So in case I didn't pick that up on the mic, he said not painful, but the odd sharp scratch.
When he was putting the filler on the bone, I just felt it slightly, but not much at all, really.
Okay, cool. And as the cannula moves around, as it changes direction, it's okay to feel?
Yeah.
So it's just a slow process now, just being patient again, because we're blending, and blending is the bit that takes more time than the filling. Because I'm trying to fill, but I want it to connect to everything else around it. So blind volume here is a bit of a disservice. It's a really calculated, careful use of volume, and also making sure it sits with the volume that Mark does have around the other areas, the positive vectors, smoothly.
Yeah.
And then just a little bit of subcision, just positive as well, isn't it? Just,
So when Amit says subcision, what he's meaning is there's any kind of little resistive tissue there, connective tissue, or scar tissue perhaps in some acne cases, just kind of break that up physically with the cannula. And I think one of the common mistakes that novice injectors make in this region, or any kind of technique like this, is they think, okay, my cannula's reached the end of where it needs to go, and I'm going to do on a 0.5 mil and do that entire 0.5 mil in one go. And they squeeze really hard and they leave a massive sausage of filler, and you can see that sausage through the skin. As you get more and more experience, or as both of us have become more and more experienced, we've learned that actually sometimes slower injecting is better, because if you have less coming out each time and you constantly keep it moving, it's harder to see where you've actually put the filler, and that's proper blending as opposed to leaving behind a large sausage. And you see that especially, I think, in the nasolabial follicle.
Yeah.
People get the cannula in there in this particular region, and they release one big line of filler, and you see it. And it's like I said, it looks a bit like Homer Simpson. And this is why he's taking his time with this, going back and forth, back and forth, back and forth. This is real time, and it's not sped up, so you get an idea of what it's actually like for in the minds of people like us, and what it's like for the patient to go through it in real time.
Because over time, Mark will age with this filler. Like most MRI studies now showing that it can be there for about a decade or more.
Absolutely.
So another decade of aging, and Mark would have lost more of his own natural volume. So the last thing you want is, as his skin thins, a sausage of filler that doesn't look visible right now, but in 2 or 3 years starts looking like it's protruding and he needs dissolving, and then he's left wondering, did I do something wrong? Did I migrate the filler? If it was actually just placed as a big wedge, and the skin was able to disguise it at that moment, but down the line it wasn't.
Not enough, So how much can you talk to? So how much volume you?
So yes, they took the whole syringe. That's how hollow the buccal cavity was, and generally it's a large area, so it can be quite what I call a hungry area.
And then project out. It's improved.
Yeah,
I think potentially it could even take more. I would say.
I agree. Yeah,
I think that's improved probably about sort of 50 to 60%, based on my viewing angle here. I think I'll be surprised if it takes another completely full syringe. But I think a significant portion of it for sure.
Yeah. So I've got a little bit left from a previous syringe. I'm just going to use that up here, and then we're going to go in and see if there's any more needed. But I knew this is going to be the area that needed the most in terms of blending. The other area is just fine tuning more than anything else. This was true volumization in an area where there's no bony contact to be made.
And there's an element to be said here of this trend that you get in some people that want to remove their cheek fat, because they want that hollow cheek, like a model look on a catwalk. The problem with that, it actually ages you as you do get older, because your entire face then caves in. And when it caves in, you look incredibly, incredibly hollow and skeletal, because you've lost that. So my advice personally is, in probably the vast, vast, vast majority of cases, removing your cheek fat from the inside is really not a good idea. And I think things like fillers, which to a degree are reversible and dissolvable, is a much better option to do something like that
Or
around it.
if they're worried about the chubbiness over here and they want to reduce that and get a bit more of a gaunt cat-like appearance, you mentioned, then accentuating here will make it look that way.
Absolutely.
Yeah.
When you stretch the skin above and below, you'll get a little bit of that concavity anyway. That's looking much better. That's really fantastic. So there is an element to this sort of movement here, facial movement, because Mark had lost fat over time, as we all do. That's one factor, as you'd expect. But there's another factor again, which you'll have, which is just facial movement. Based on where his muscles are positioned and his facial expressions being done, that's why different people get wrinkles in a specific place on their face. And the line that Mark had here, the reason that line is in that exact position is based on his movement. So even though this looks much, much smoother now, and it will do when we sit the patient up and you see half and half, treated, untreated, it's not going to stop his facial movement. So it's not going to magically disappear that line completely. It's just going to make sure that it's much, much less noticeable because it will replace as much of the fat as possible that was underneath. And this is still to
1.4.
Yeah, in this region.
Yeah, a little bit more. Probably it's 1.6, 1.7.
Yeah, it looks about that much. So same entry point. We don't need to enter again because that will stay open for the duration of the treatment, of the appointment. There we go. You may or may not have seen that little pop on camera there. That is just going through the resistance of some connective tissue, which is perfectly reasonable. And as you can see from Mark still lying there the same way, it's not painful either. We don't have nerves inside connective tissue. It looks worse than it is, just like filler under the eye. Some people may get scared. Oh, it's so close to the eye. Doesn't mean anything. It's not going to hit the eye. The cannula is not going to magically jump through and hit anything. It's typically going to stay in the layer that it's in, and that's how we travel parallel.
And by this point now, Mark's got so much lidocaine from the fillers with
the anesthetic.
he's going to be pretty numbed up here now.
Yeah.
Okay, so we're just coming into this lower section of the nasolabial fold now. I'm going to use the same entry point to just reach that area and just do a little bit of soft filling over there, and then we're pretty much done with the buccal area.
One thing you may have noticed just there, and possibly a little bit now, as I pushed the cannula forward, the skin puckered up, just squashed and folded very slightly, and then it released. That's the pressure of the cannula pushing against connective tissue, and that connective tissue is then pulling on the underside of the skin, which is why it puckers. And then when he breaks through that, that's when it releases. And you can see there, right there, and then it'll put, there we go, and now it's flattening off. And that's okay. There's no harm with that. There's no damage with that. He's just going to smooth everything out, and everything will heal afterwards. It's really not a problem whatsoever. And that's looking fantastic.
Now, from more like a cellular perspective, Dabs, what would you say that does to the basement membrane / the fibroblasts in that area? Are we doing anything to kind of help in any other way?
It's a good question. So what I'm asking is, when we do that, is that physical stimulation going to help the skin tighten up in some way? The truth is, sometimes it can, sometimes it can harm, sometimes it does nothing. It's to do with how traumatic you are with your cannula as well. Sometimes when you're really traumatic, all that does is create a little bit of scar tissue, which technically is collagen, but it's not the type of collagen formation that you'd want. When people are, using multiple needle entry points, actually sometimes that can generate a little bit more nicer collagen than something like this. And let's remember here, we are in the superficial fat. We're not in the dermis, which is where the fibroblast cells are that are producing all this collagen in our skin, as well as the keratinocytes. And because we're in a superficial fat, the only real stimulation we're doing is mainly for some of the connective tissue that we break through, which can re-heal, really not a problem. But in terms of the actual skin, the dermal quality, I'm of the opinion it's probably not going to create anything significant, but there may be an appearance of that if some of the connective tissue heals up to be a little bit stronger than before, and that has possibly a little bit of a lifting effect in certain areas. That's as far as I would go.
Yeah, that's good to know, yeah. So I've just been working in blending this upper section, and I'm popping through the zygomatic cutaneous ligament, and just kind of really blending it all together seamlessly now. It's just finishing touches now. So,
and when we talk about these ligaments, this is not a formality. These ligaments separate compartments in the face, and when you put a filler in a compartment, sometimes it can go to a direction, sometimes it can't because it's restricted by that compartment. So, if you're a novice injector, if you're watching this because you want to get good at dermal fillers, my better, I'm sure Amrit's advice as well, don't just learn the nerves and the vessels, also learn the compartments of the face and the connective tissue. So for example, under the eye, learn things like the zygomaticocutaneous ligament, the orbital retaining ligament. These compartmentalize the areas, and if you know where they are and what they do, you can place filler this side or that side of them and have it held in place. Just like when Amrit was treating the jaw angle, the gonial angle, his needle was angled in a very peculiar way on purpose, so it can be held in the pouch that is anatomically created there. So these ligaments and these compartments are very, very useful. We can take advantage of them. And if we don't pay attention to them, that's really when people can start to look a little bit odd because of the migration that we get over time with the filler move, or filler dislocation, I should say, not technically a migration there. And this is almost the end of the syringe now here, actually. It's a little bit more than I expected.
Yeah, me too. Yeah.
But
it's working so well. And then there were just a couple of pockets where I was able to get into where the blood vessels would run. And I can just kind of reach all the way up here.
Yes.
I actually modified a little bit, went a bit deeper with the cannula onto the bone, and just was able to put a little bit more filler right up into the anterior cheek from here.
Yeah.
So
almost sort of multi-layer.
That's it. Yeah. Yes, because it's just kind of sitting in there so well. I want to try and get the
looking good.
Very small. Yeah, that's little bits left now.
What a difference I can see from left and right here.
Yeah, I'm excited for the halfway position. Yeah.
So we have another syringe. This is syringe number 5 or 6. I've lost count now. Whatever it is.
Yeah, but we didn't use a teardrop one completely, so that one still is like a fraction of that one. So I discount that one. So yeah, we're on 5.
Still using cannula, and we're now going to finish off blending in the areas that you can see that still have some color, some ink to denote where we're going. And I will hold this for us here.
So if I just bring Mark over to the side here, that's brilliant, Mark. Just got a small amount to do around the chin first. So just a little bit of measuring.
Yep, he's putting the cannula tip as far as it needs to go, so he knows where to enter, like a makeshift ruler.
Big breath here, Mark.
Now what Amrit is doing here, he's mimicking the cannula with the needle. What I mean by that is, if he needs to go into one particular layer, he'll only go into that layer with the needle. So the cannula tracks and ends up in that. If he needs to go very, very superficial, close to the surface, no point putting the needle deep, because then the cannula will also go deep and you missed your layer. So that needle, that entry, is mimicking where you want to be, and this then follows it. I think one mistake that some people make is they're always too scared to go far enough with the needle, and it's not actually broken through, and the cannula then can't actually enter the skin.
Yeah. It's a tunnel. It's a tunnel maker.
Exactly. Yeah. Exactly. In my opinion, you do need to go through the skin, and actually a couple of millimeters at least into the layer that you would like. And there's no point worrying about trauma, because a cannula is going to go through there anyway.
Yeah. And it's that trauma.
Exactly. Yeah. Exactly. So he's aiming upwards, and he's trying to basically blend this area, which is a transition area from the chin into the cheek. And he's going to go in a sort of V-shaped fan, similar technique, keeping the cannula moving, not too much in one position, and really actually properly blending one area on one side with the other, like butter on toast. When you do these techniques, it's not just about trying to volumize a particular hollow area. The hollow is not necessarily the problem. It's the disconnection between the areas of the face, either side of the hollow, which is the problem. So what he's trying to do, like we've just done before, is connect the hills together by filling the valley in between, so it just comes nice and smooth. So you don't always actually have to mark things, no pun intended, I just name is Mark. You can just look at where the light is reflecting, and where the light is catching, it's probably a hill, and where there's a shadow, there's a valley, and you're basically chasing the shadows, if you like. So this is a much smaller area than what we've just done. So he's used a lot less. I'm going to guess, what, 0.5 mil, 0.4 mil?
Yeah, 0.4.
Yeah, 4 mil, something like that. Not a huge amount.
There we go. Just the last little section to finish off now.
Yeah.
How was that, Mark? That's about as sensitive as it gets.
Yeah, that was fine.
Oh, good.
It's good.
Good. Okay. So initially, I was going to go and cover this area, but the jawline injection has done such a good job. I don't really need the balling down here, so I'm going to kind of modify it. Okay, a little bit more at the mesenteric ligament at the front over here.
Yes. So the mesenteric ligament is a ligament at the front side, the anterior side of our jaw clenching muscle, the masseter. And what Amrit is doing, again, he's not bringing the needle all the way in. He's going just a couple of mil so that he stays in the layer called the superficial fat above the SMAS, submuscular aponeurotic system. And if you stay above it, you're less likely to damage any important structures in the face. So again, the cannula is following the angle of the needle to try and find the entry point. And when he's in, he's going to flatten off, as is just done there. And now he's going to travel forward because he's in that right plane. And it's going to be very difficult for a canyon to break through from one plane to another unless you really try to do it on purpose. So if you're nice and gentle, it will stay in the layer. And in this particular place, the layer he's trying to stay in, like I said, is the superficial fat, suprasmas, above the SMAS layer. And he's just tenting that. He's lifting it up so he can see whether or not the outline of the cannula is visible. If it wasn't visible at all, and he has no idea where the end is, then it's probably too deep. So it's a useful technique to do that. And you probably saw him go side to side as well. I think one advantage of putting the cannula side to side is that if you're in a vessel, you can't go side to side. So it's a nice safety check. A lot of people think you have to use ultrasound now. Actually, you don't have to. Putting a cannula in, and instead of going forward, you put it in a little bit, turn it from side to side like this. And if you can turn, well, you're not in a vessel because a vessel would restrict turning otherwise. So it's a safety check and it's also a depth check. Very, very crude, very, very low tech, and it works perfectly well. So you're entering this particular area again, where we were just treated before. Obviously, last time you went in this direction, and now you're going in that direction. What's the thinking behind that?
So especially when I'm going into the superficial plane and then there's a lot of volume loss, there's no bony plane to project off.
Yeah.
So then it gets to the point where the cannula enters distally or farther away from there. Up here, I could feel really well, but I couldn't do much here because I was so close to the exit. Either the filler will leak out the exit or it looks a bit lumpy and bumpy. So covering that area where the tip of the cannula now with the entire length in is around that area where we entered before, I'll get a better seamless finish or an overlapping.
Yeah.
And sometimes that overlapping or that cross hatching kind of gives you that
Smooths it out.
transition. Yeah.
I think it also allows you to check for connective tissue in a different direction.
Yeah,
in the perpendicular.
I always, when I'm covering this kind of area, because there is a lot of connective tissue, it's nice going perpendicular to your first entry.
Yeah.
To then get a little bit of a different connective tissue feel.
Does it feel about the same as the initial entry?
Pretty much, yeah.
And we're almost at the end of this syringe here. Probably got about 0.1 left. Again, always keeping the cannula moving. Looking good.
Honestly, when people find it difficult to get the cannula in and there's connective tissue, they immediately assume the worst. They think they're against some important nerve or blood vessel. They don't realize is that when you're against a important nerve or blood vessel, a nerve, obviously the patient will feel like,
they will jump.
Yeah. But with a blood vessel, you won't really feel that. You won't get that level of resistance because the connective tissue is much firmer than the endothelial lining of an artery. So if you're getting a lot of resistance, it's just connective tissue really, isn't it? Yeah. But it comes down to the lack of anatomy awareness. A lot of people just get taught like monkeys, needle here, needle here, needle here, blah, blah, blah.
Like a template.
And that's it. Blend it all together with your hands and that's it. Yeah.
And that's an important point. We'll talk about that in the podcast, but some people will treat everyone the same. They'll say package. So this injection point, this one, this one, this one, and this one, and the volume 0.2, 0.3, 0.4, whatever in each one, and then everyone gets the same. Everyone looks the same, and some people will look good by chance, and actually probably most people won't, because you've got to treat every single person as an individual, like we've done today, by really highlighting which areas need volume, which areas don't, and to leave them alone. That looks fantastic there.
I'm glad we managed to do all that without a bruise.
Yes, exactly. Exactly. But I think also, part of the reason is, obviously we know where the vessels are, but also Amrit's used a very fine needle. That's a 30 gauge, I think, 30 gauge needle. And also your cannula, I think was a 27 gauge by the looks of it. 27 gauge cannula. When you use fine instruments, it is a little bit easier to avoid bruising.
Good. If I just turn and mark the other way, I'm really pleased.
Yeah.
That makes a difference. Yeah.
So what we'll do...
so it's
5 syringes.
So 5 syringes.
And a little bit
and
of the
0.15.
And 0.15 of the 6.
Yeah.
So what we'll do, we'll get Mark to sit up on camera. And as he does that, I am actually going to get my phone. This is all in real time. I'm going to get my phone and record on this as well, so that you can see in a little bit more closer detail. So, yeah. So Mark, if you want to sit forward, that's it. I've got you there. Not to make you fall over. There we go. So I'm sure on the camera, the editing team can sort of zoom in. I'm also going to take a video coming from the side. So this is the untreated side. And then we'll get to the front. And you can see quite a significant difference there. Everything kind of actually picked up on the face. It's lifted almost as well.
Yeah, if I just bring Mark a little bit this way, that's it. And then Mark, if you look up to the ceiling a little bit, there we go. And then looking straight ahead in the distance, there we go. And just looking a little bit this way as well. There we go.
Yeah.
That kind of really shows up quite nicely where we can kind of see the fat prolapse of the false tear trough. But it's all disappeared on this side once we blended it all up.
Yeah.
And then just revolumizing the structure. And it looks like we augmented his cheek on the side, but actually we've just merged what he already had with the areas that are missing.
Yeah.
And then just a lot of the buccal works made a big difference on that side. And
just for sure.
A little bit as well. Yeah.
That's it. So, all good. You got everything? Yeah. So, with some magic in the edit, we've now come over to the other side. We actually had quite a long break here, just so Mark can relax and go to the loo and things like that. We've now put numbing cream on the other side of the face, which we're now going to treat. The microphones are charging, hence why I've now gone to a BBC reporter style handheld microphone here. And we're basically going to match everything. I mean, there's one area that we didn't do, and that was around the mouth, the perioral, right? So we'll talk about that fresh when we get to it, but you crack on, and we'll commentate on everything as we carry on. Are you going to do it in the same order as before?
Pretty much, yeah. All the same things again. I was just saying to Mark earlier, it's literally a copy and paste, so he knows exactly what he'll feel and the sensations and the process. We renumbed that side because we knew it would have worn off by now. And then once I started to bring the filler into the areas, the lidocaine in the gel will start taking over as well. And then by the time we kind of get to the end, when we're working on the perioral area around the lips, which is the most sensitive. Now, we don't need to do much for Mark anyway, because the goal isn't to give him a larger lips or an enhancement of the lips. It's just more the fine lines at the borders of the lips and the upper lip here, which we want to just smooth out a little bit. But I'm going to be relying on a lot of the lidocaine from inside the face, from the fillers we've already done, particularly, for example, around the peripheral fossa, to just make it more comfortable for when we come into that area with a cannula towards the end. But yeah, I'll do all the same stuff again, and I'll kind of run through things. But the only thing I did notice is it's always the eye area where we under-treat it, and I was just having a look as I was just seeing Mark having some coffee, and I thought, I just want to refine that area a little bit further. So at the end, I'll just go in and do a little bit more on the eyes just to really get them as good as we can.
Yeah. Sounds good. I mean, yeah, I do the same thing. I typically underfill. Since I started using the filler that I do, I probably fill to about 90-95%, whereas before I was probably filling to about 75-80%. So now, Amrit's going to what we call the anterior cheek. Again, he's going through the markings, but it has been disinfected. Plenty of chlorhexidine here. And again, he's pointing the needle towards the midline. And I'm going to ask you, Amrit, this is sometimes where we find asymmetries in the face. And sometimes they're visual, which, I mean, we all have that to some extent. But sometimes they're not visual. And when I'm treating one side of a face and I go to the other, the distance from the skin to the bone is different. Sometimes it's deeper on one side because there's more bone wearing away or bone atrophy on one side, and it takes a lot longer for the needle to make contact. How is this feeling for you?
So yeah, when I examined for Mark, actually he's got a noticeable asymmetry on this side anyway. It looks like he sleeps on this cheek because this is where the bone has been flattened anyway. So he's got a less of an arch on the cheek on this side. So I kind of anticipated that it would be closer together to the bone anyway, because there's just more volume loss on this side overall. But it's not too bad actually. I've done a similar amount. I've done 0.1, 0.2, and it's kind of, I would say he's a super responder. He's got thick skin and very little volume below the skin. So anything I put in there with a gel is making a big difference. It's just I'm going really slowly so I can kind of make sure it all sits really, really as close to the orbital rim or the junction above as I can, because it just means I need less filler to blend in the eyelid afterwards. And it moves a light reflex as high as I can take it. So it doesn't look like his cheek's heavy or sitting low down. I want it to sit as close to the orbital rim as I can.
And I think one mistake that newer injectors make, especially in this area, is even if they're trying this technique, and I've noticed this, where both of us, we first met at a particular organization in the UK, I noticed in that organization when people were learning this technique, one mistake they made was they were trying to copy what you could see. What you can't see is the contact with the bone. And they would think you get the needle, you get the syringe in this angle, you enter the skin, and then you just eject. But actually, if you're not making that contact with the bone, then I don't think you're injecting in the right way.
That's right.
And talk to me about this walking the needle technique that you have here.
Absolutely. So if you kind of watch me, I'm going to come back a little bit because I'm going to move to a different part of the bone here. Now it's really important that I can just go in and just anchor the needle on the bone. But sometimes when you go in very quickly, or you've been on the bone for a previous injection like we already have done, the needle does blunt a little bit, so it's not able to cut through the soft tissues as precisely. So instead, what you end up doing is you end up anchoring or pinning the cartilage or the connective tissue, the soft tissue underneath, onto the bone and filling at a more superficial layer, but you're touching something hard. So you convince yourself, well, I must be on the bony layer. The filler is sitting on the periosteum, whereas actually the filler is coming out on the deep fat, or maybe in the SMAS or the superficial fat. It's really about how you anchor these down. So I'll share a few images with Abs to kind of overlay onto this into this video as well, so you can kind of see the different versions as to how these in terms of animation show up, this anchoring approach. So if I hit the bone, I want to make sure that I've actually gone through all the layers or popped through the layers. My needle and my bevel are on the bone and everything is above that, so that when the filler comes out, it sits on the filler. The filler isn't sitting inside the fat. So that makes a big difference in efficiency, in the actual anchoring of the filler to the bone or the bonding. And it stops the tissue then dragging the filler down, because the tissue, if you have a look, it's mobile on the bone, right? I can move the tissue around, but I can't move the bone around. So I want the filler to sit on the bone and not in the tissue, where then it's also mobile and doesn't look dynamically as good when the patient expresses and stuff. So and then there's quite a few areas of the face where I want to reach the bone. I want to put a little bit on some positions, but then I don't want to come out and make lots of punctures to go into to cover different aspects of the bone. So I'll use the 13 millimeters or the length of the needle to allow me to then walk up the bone and put a little bit there, and walk up the bone and put a little bit there. So then I can kind of from one entry touch 3 different areas of the bone and fill those to get a better finish.
Popping the needle up.
Yeah, basically I'm kind of hitting the bone and then moving up and hitting the bone at a new place. But I'm only filling on the bone, but I'm traveling in between like a kangaroo.
Yeah. And I think this is probably taking, visually at least, a similar amount of volume to the other side. Would you say so?
Yeah, pretty much. Yeah, maybe ever so slightly less, possibly. Yeah.
So we're going to do that technique again, just a slightly different entry point this time. But again, notice how he's not going perpendicular to the face. He's not going straight in like this. He's now doing what we call the piriform fossa, or the top of the nasolabial area. And the reason he is going at this angle instead of vertically down, like we said before, is because he's trying to direct the filler once it leaves the needle. Sometimes if you just put the needle in, whatever direction you want, you can't actually control where the filler's going. Even if the needle tip is in the place that you want the filler's actually going somewhere else. So this is a really good technique to slide that filler almost into the correct position that you want. And what I find also is when you do this particular technique, it also sometimes it makes the nose look a little bit more compact and not as splayed out. And when I do this technique, if I do one side first, the edge of that nostril tucks in a bit, and it's very easy to see when you've done one side and not the other. Do you ever find that?
Absolutely, yeah. And actually, just touching on the point you mentioned before as well, Abs, this is an area where I manage a group of newer injectors, and I kind of give them tips and advice, and they kind of come to me when they've treated a patient. Sometimes it's not gone well. And this is the most common area where they can't get it quite right. And although they're where they should be, because of where the needle's, like the position of the needle, or the way they've not exited all the layers, they might still be stuck in one of the layers, even though they're feeding the bone, that the layer's been pushed onto the bone, so they're feeding the hardness translated through. And then they push the plunger and the filler ends up tracking all the way up the nose, and they have this kind of a blob sitting on the side of the nose bridge over here, or sometimes it tracks up here and has a blob over here, and they're like, this area hasn't changed, but I put the filler in the right place. What happened? Where did I go wrong? And from the photo straight away I can see it. And the thing sometimes they clinically don't realize is you can do all the steps that you've seen or been taught to do, but it's the tactile sensation is the part that's very hard to teach someone, isn't it? It's almost like
show it.
teaching someone clutch control verbally.
Yeah.
Like you have to feel that bite of the clutch to know what that feels like and know where you are. So it's that tactile sensation that I find a lot of injectors miss out on. And having come from an anesthetics where we do a lot of epidurals, which you're literally a centimeter away from the spinal cord, and you've got a very big long needle, so you could easily puncture that and paralyze them. So we use water to then use loss of resistance, and the water then can go into that epidural space, and you suddenly are able to get this very fine plastic catheter into that space. But it all is done blind, and it's all done with a very high risk of where you are, but you're doing it all on tactile sensation. So, and it's an area where they kept saying ultrasound will come in and take over epidurals, and it never has, apart from severely obese people. You kind of sometimes need to feel the space between the bones with ultrasound, but it's a blind procedure, and it is all relies on tactile sensation. And fillers will pretty much always remain blind tactile sensation procedures.
And one thing that I'd like to say to the people watching, the viewers, is you can go on Instagram and look at any before and after and think that looks great, but actually, you can Photoshop those. You can get something that looks great now, but then looks terrible down the line, and you'll never know. You don't know whether it was a good and safe technique. But the most important thing is you don't know how good an injector they are. And they can have a good before and after picture, but if 2 or 3 weeks down the line, the filler's completely moved because they were not injecting right, like this tactile sensation we've just spoken about, it's never going to turn out right. And you will never know what someone's tactile sensations are like, what someone's hands are like, what their aesthetic eye is like. And this is why it's not easy to pick the right injector to go and see. And this is why I've come to Amrit, because I know he has those things. I've watched him inject. The only way really that you'll know if someone is a good injector, and I'm sorry to say this to a lot of you, but is to go and train as an injector yourself and then judge someone else. Because through social media and reviews, you've got no idea. It's absolutely nothing.
And especially now where I'm seeing a lot more, I was saying especially now where I'm seeing a lot more social media content by injectors that generally are newer. They'll use the titles like advanced aesthetics practitioner, which means nothing. There is no one that gives you this qualification. If you call yourself a professor of aesthetics, it is very hard to then quantify that. So they can come to any claim, and then they sometimes don't even show you before and after photos because they're not treating a large number of patients. So what they end up doing is just drawing on their own face dots and then talking about something as an educational piece, and then relying on that educational piece for you to then, for them to buy your trust based on, come to me, I know a lot. And sometimes as an injector, knowing more than them, I realize actually you know very little, but it's enough for the layperson to then be coerced into this treatment and believe in you. And then I get all these, sometimes even my regular patients see that content and then come to me and they're like, well, I'm too scared to change because I've been with you for years and I know you know what you're doing, but I have this jowl and I'll be told I can have a bit of Botox on the side of the jowl. It's going to suddenly lift everything up. And I'm like, no, your neck platysma Botox is not going to fix your jowl, no matter how many American videos you get shown by these, other practitioners. And it's just dots. There's no actual evidence. They don't even see the after result. They're just told, if you do something here, it suddenly lifts up. And they're sold an absolute lie. But it's done so convincingly that sometimes I think aesthetic practitioners have become snake oil salesmen. They become such good at selling something that actually they can't deliver, but they rely on a repeat turnover of patients, and they don't have a loyal following at all. They can't build that following because they're not good.
This is why I accept almost no new patients nowadays. And I don't need it. I'm just not interested. And unfortunately, there is no other way of knowing who's a good practitioner. You've got to train yourself and then do it. People used to ask me when I was a dentist, what tips have you got to find a good dentist? How do I know if they're good? Like if they're maybe in a different country. And I said, well, you don't know. People could say, well, look at reviews, but anyone can write reviews. They might say, look at the before and afters. Anyone can get lucky and have a good before and after. You've absolutely no idea. And the only way is to train to be a dentist yourself and then go and judge them, which is a difficult thing to hear for a lot of people, but it's the absolute truth. Getting back onto this now, so Amrit's now treating the temple. In the temple, there's a particular spot which he's now in, and that one particular spot, I think there's a paper published by Arthur Swift a while ago, which showed that it was very avascular, which means there's a very low likelihood of finding any blood vessel there, which is why we're using this technique. And this way we can avoid what is known as the deep temporal artery in this position. We want to avoid that because we don't want to block that artery. So that's why he's going in this particular region. Now, some of you are probably thinking, well, if you only inject that one place, what if the hollow is a little bit different to that. Because this particular place is a bit of a sort of pocket inside, and there's a muscle above it called the temporalis, which is what clenches or contracts when we clench, right up in our temple here. The movement of, or the contraction of that muscle will actually act as artificial massage on the filler he's done here. So that's why there's not a massive need to massage this. And the natural movement of that muscle will actually shift the filler into the deepest point anyway. So it's like a sort of smart filler almost. It tracks into the place that it's needed most.
I think we're like the Mariana Trench in the sea. And, you know, you pour some very heavy cement into that trench, it's automatically going to, by the action of the sea above it and the gravity, is going to then suddenly sink into the deepest part of the trench and sit there. So that's pretty much what happens with this as well. I can kind of, as long as I'm going slow and I'm not forcing the filler to track somewhere against where it wants to go, and I'm letting it then just naturally move under the pressure of the muscle above it, it will just do what I've done here. It's just automatically fuse the area. Even though I couldn't inject in the deepest part of the back here, it's automatically gone into that area.
I think it will get smoother and smoother over time as a contraction of that muscle happens. How did that feel in terms of depth compared to the other side?
Much deeper. It's an area that's surprisingly deep. It catches you off guard every single time. The anterior cheek, if I went as the bird flies the shortest distance, 90 degrees, it would be about half the needle in and I would have reached the bone. Here, I went pretty much 90 degrees and it was a whole needle and then a bit of indentation. Yeah, that's it, to get to that point. It's because the master muscle is quite fleshy. You go through it and you realize it's a long way down to reach the bone. Even though when you touch the skin here, it feels like you're feeling the bone straight away. Yeah, but that's worked really well.
Yeah, I think again, just for people watching this, the technique Amrit's chosen here is to go with a needle in this area. You can actually use a cannula in this area and actually a fan very superficial under the skin. In the temple, really, there's two planes that you can place filler. Well, there's three actually. One is just under the skin. One is in between the fascia, which is called interfascial, which is the next space down, if you like. And then there's one which is very deep, which is what you saw Amrit do there, which is deep onto the bone. Which one you use is not your choice as a patient. Your choice as a patient is the result that you want, and your practitioner should be well versed in all three of those techniques and use whichever one is appropriate for you. Sometimes it's more than one. I've done cases where I've used all three in a really deep hollow and sandwiched it together, and that works quite well. If you treat just under the skin, or if you treat interfascial, it's a little bit more difficult to lift the brow. If you go very deep and you push that muscle up, the muscle is going to actually pull the brow up as well with it. So there's right and wrong ways, and depending on what the patient is after. And here we've decided that just going deep onto the periosteum as deep as possible is perfectly okay, as we can see from the previous side. And I think you've just done a little bit of the cheek there, was it? I missed it.
Yeah, I just did this, basically the transition between the zygomatic arch and the beginning of the maxillary bone. And then there's a little bit of a crater there, usually which is filled by the deep cheek fat and then the buccal fat below it. So that area you can kind of normally examine and palpate, and you can kind of feel a little bit of a step or a notch. And that's where I got my needle into.
Suture.
Like a suture line, yeah. And I just bolused and it kind of just projected that hollow out, which I can do much more efficiently with a needle there than if I was trying with a cannula superficial. I just lose a lot of product to get the same result. So where I can, I'm trying to get as much filler economy or efficiency as I can, so that then I can reduce the volume that I'm going to need to use in the cannula later down the line.
So I mentioned something called filler economy there, and it's basically getting the most bang for your buck in lay terms. And if you're someone who's trying to learn about fillers, if you're a practitioner yourself and you're new to this, I would recommend reading a paper by Sebastian Cotofana that talks about something called SVC, surface volume coefficient. And this talks about how much skin projection you get per unit volume that you inject based on different parts of the face. So for instance, where Amrit's injecting onto the chin here, the distance from the skin to the bone is not a great deal as compared to the temple.
I'll let you coffee. I can tell you all to this. It's okay.
So the distance from the skin to the bone in the chin is not as great as maybe the temple. And so as a result, when we inject the same volume in the chin or in the temple, the chin will project more. And this is why we look at things like SVC, surface volume coefficient, and what Amrit said there, filler economy. Kind of looking at the same thing but with different terminology, that's all. So what he's doing is he's going at a slight angle, and he wants to project the chin in a particular direction to match this side here. And he's going to try and feel for contact with the bone, with the mandible, the jawbone. And sometimes this area is a little bit sensitive because you may be able to palpate it yourself just here on the bone here, sort of just up from the jaw and sort of between the jawline and the mouth, we have a little kind of hole, an exit hole in our anatomy. And this is called the mental foramen, where the mental nerve exits. Comes off very deep from the bone, and then it becomes more superficial to the surface over here. Because of that presence, sometimes contact with the bone is a little bit sensitive here, but it quickly subsides because of the anesthetic in the filler, if your filler has that. So now Emre's done that, he's trying to get a little bit of symmetry in the chin. And how's that looking to you from that perspective?
So I got the projection to where I want to. I just need the roundness now, so I just need a little bit more over here. And it's an interesting structure. If I make a fist, I always use the fist as a good example. Just underneath the chin, we're basically in the neck. And then just on top, we're not far from the lower teeth. And then we have the gums and we have the base of the chin. And then we're basically in an area where we're on a curb. And I can end up on the edge of the curb, I can end up off the curb, I can end up on top of the curb. And that 3D aspect is really important to then visualize mentally, to know which direction do I want the skin to project in? How do I want the structure from a 3D perspective to look? So where should I place the needle and have then the filler track in front a little bit to know? So it's one of those where having a bit of being a visual person makes a big difference. So for me, I'm very visual. I can kind of then almost see into the X-ray vision almost of the where the bony position is, and then the tactile sensation of me touching the edge of the bone, walking up the bone, seeing the filler then project the right area, modifying and moving just millimeters to get it the shape I want it makes a big difference. But it's an area that can easily then go wrong too. And it's different because for female patients, I wouldn't be going as laterally as this, because I'll be squaring and flattening the chin like we have for Mark. I'd be going for a more central, narrower chin. And then that you have even less room for error, because then suddenly you can end up with a wonky chin because it could be off center slightly, isn't it? So yeah, there's a lot of things to think about as you're doing this. And I think sometimes we make it look really easy and we don't explain it as much as I should.
What we see on social media is needle goes in and the face looks great. But actually it is far more, is what's the angle? Where's the contact? Which side of the needle is the bevel coming out, etc., etc. You know, how long do you squeeze the plunger for, etc. You know, sometimes in this area, I find it's useful to place a bolus of filler deep wherever you want to on the bone, and instead of letting go of the plunger and then pull the needle out, sometimes I'll actually squeeze a little bit of a line retrograde as I come out, and that gives a really good projection because of the way it kind of supports the skin as well. That's looking nice. That's looking very nice. So yeah, in terms of how we make it masculine, we do have some corners and we do have a little bit of width. Roughly speaking, it's about 1.5 times the width between the eyes, roughly speaking. Some people will say it's the width of the mouth. However, the problem with that is, what if their mouth is not quite in proportion with the rest of their face? Then you're going to make a chin out of proportion as well. So for me personally, the metric I use to determine the proportion of the face is the distance between the eyes. So the inner corner is called the medial canthus, and the distance between those is very determining of the rest of the face. In my opinion, it's better to look at the whole face rather than individual areas, because some people will say, well, the maximum projection of the cheek here, if you draw a line from A to B and C to D, where they cross, that's where the cheek is meant to go. But how do you know if A, B, C, and D are in the right place just to start with? Because if they're off, then the point where you put the filler is going to be off as well.
Especially as the age. Yeah, as the age, those points will change, and then you're basically not taking them back to where's optimal or ideal for them. And the intercanthal area is the only bit that doesn't change as we get older. That stays fixed, and everything else changes around it. So we should use that as the most concrete, reliable kind of anchor when we're designing the face.
Absolutely. Even this is slightly off topic, but just to illustrate the point, there was a Nazi war criminal found in America, many decades after the war. I think it's not that long ago from now, and they were trying to determine, is it him? And they looked at old photos, and even in the court trial, one of the things they focused on was the distance between the eyes, because it doesn't change as we age. And so I think that's a much better way to gauge where we place filler, rather than points that are mobile and move as well. So would you say the chin is done? You're going to add a little bit more there?
Pretty much. I'm going to come back to that in a moment. I'm just going to do the jawline angle at the back.
Yeah.
And then see how the hammer changes and then modify the hammer. Yeah, I need another millimeter or so just here, just a small millimeter. But I'll do the posterior jaw, come back to that. which are all like, I could equally just carry on here, then come to that. There isn't really a 100% way of doing it. It's almost like going to a parking bay. I could drive forward into it, I could reverse into it, I could parallel park. You have all these different maneuvers you can use, and you're just making your best judgment from experience as to what has worked the best in the past, what's been the safest, what's been the most economical from a filler perspective, so that we're not just ballooning faces.
Yeah. So we're still in the needle, so we're still using the sort of more viscous, the more dense, the more thick filler here. And he's now going to the back of the jaw, the gonial angle. Again, it marks leaning away, and it's palpating for the bone, so he knows exactly where to guide his needle.
The area people get lost the most, because there's a lot of structures over here. You can go too far below and you're in the neck somewhere, and your needle's just wandering around, and you're just trying to find a hard surface, and you don't know, are you on top of the bone, are you on the edge of the bone, are you under the bone? And then you've got the parotid gland, which is a salivary gland, you've got the masseter muscle, you've got quite big arteries either side, facial artery and external carotid artery. So it's an area where what seems like an easy area to hit when you examine and palpate it, but actually when the needle goes in, you find out it's quite hard to find that pouch. And this is where I've seen practitioners lose a whole syringe of filler, and they've managed to bolus it, and then they sit the patient up, and it's just done nothing. It's just made the face bigger in every wrong dimension. So yeah, it's an area where I always say palpate 3 times, inject once.
Yeah. So what Amit's done, he's left-handed, his right hand is tensioning the skin and palpating for the edge of the bone. Now, if he places his finger where the edge of the bone is, and then he knows to put his needle superior to that, above that, then he knows it's going to go towards the bone. So his right hand is guiding the syringe that's being held by his left hand. And it's always good to put your finger, where you don't want the needle to go. And then if you put your needle just next to your finger, you know you're always going to be in the right place. It's a very useful technique. And also another thing you'll notice, which a lot of novice injectors don't do, look at the way that his left hand is completely still because it's resting on his right hand. Some people, their hand will simply hover in the air. There's a strong connection from the syringe to his left hand to his right hand, and his arm, which is resting on the bed. So the bedrock is completely still and solid. If something is being held in the air like this, I would just say it's completely unsafe. So you've got to rest, and if someone said pause before you enter, your needle should be able to stay completely still instead of moving around like this. And I think that's a really good way of separating novice from experienced injectors.
If I anchor my hand to the patient, and then my other hand, my injecting hand or the needle is resting on my hand, which is on the patient, if the patient suddenly jerked or moved, because I'm anchored to the patient, everything moves proportionately, so I can't then accidentally needle stick injury myself or the patient as well. And it just kind of gives me more stability. I mean, this is a stiff filler to push through a very fine needle. So the more I can stabilize myself, the more control I can get between my 2 fingers. If I'm floating, I mean, even the choice of having my elbow nearer to my hip means I have a little bit more stability to rest on my hip, rather than have my arm extended out here, my hand's floating, and then my thumb gets tired and my whole hand starts shaking, and it translates into the patient feeling some degree of movement, which could be my hand getting tired, but they feel it's a shaky injector, he's a bit nervous, and then suddenly everything just elevates, patient's blood pressure goes up, that increase in blood pressure translates to a little bit more vasodilatation, patient, or more bleeding, more bruising. Everything can just tip the scales from a very controlled, lovely environment to then suddenly a bit of a chaotic environment where then you bleed, you have to hold it for a while, patient knows you're holding it because it's bleeding, and you're waiting for hemostasis, and then you want to rush because you don't want it to seem like that, and then you do the next one, and then suddenly everything just, I find, can escalate into a bad outcome.
Yeah, it's a downward spiral.
Yeah, that's it. Yeah, so it's a very easy, slippery slope to slide down. So anything you can do to just keep yourself really stable, really comfortable. And I think for me, having a calm environment, being a calming presence in this process makes a big difference. And now it's easier for me being in anesthesis because people are coming for an operation, I'm putting them to sleep. They're as anxious as you pretty much get in life, right? You're losing control to some drugs, to some strangers looking after you for the next few hours while someone's potentially cutting you up. So if I can bring that same aspect to this, it just makes my patients so much more happier, comfortable. So it's a nice thing to bring, yeah.
Yeah, and I think, even though I said earlier in this video that you'll never know who's a good injector unless you train to be one yourself, and then you can judge someone, That's a really, really good giveaway. How still is their needle, or is it shaking and hovering from side to side? That's, for me, that's one of the biggest giveaways. And it makes such a big difference. You're probably not even going to get it in the right place if it's hovering.
A lot of injectors like to show their actual injecting, like live action injecting. Is very few people want to inject live or inject on video. They rather show the result at the end, or they don't want to show the journey through the result, which is because they're not comfortable, or they're not comfortable enough to be able to showcase the process, because for them that's a stressful process and they're not 100% confident. So yeah, I always kind of say, is really, do you want to go to a Formula 1 driver who's happy for a camera to follow him lap after lap because they're that good at it and they know what they're doing? Or do you want to be, go to a lorry driver who might be half asleep, dozing, doesn't want the video, often the video's got to show them, swerving off the lane and going into the hard shoulder or something like that.
I mean, I worked out recently, and it's probably the same for you. I have trained over 10,000 doctors around the world now, and I'm sure it's easily more than that for you. And the amount of times I've visited a country to do training, and I will demonstrate the injection technique in front of everyone, and they'll all record me. Some of the doctors just won't inject, and it's because of ego. And they don't want to show that they might be bad or they are bad at something. And you never see that on social media if all there is before and afters.
The thing I would love, and this is very hard to organize, and I don't think this will ever happen, would be an injecting Olympics where you get like not even twins, not even triplets, quadruplets. You get like 10 identical twins in a row, and you get 10 injectors who all claim to be the best, and they all have the same product, the same instruments, just their own technique and their own eye to deliver what's best. And then you had a panel of judges that compared the results, which would then be standardized because it's the same person with the same signs of aging, same everything. And you had a multiple different category, some older patients, some younger patients, some structural, some rejuvenation. And then you could actually categorize who's really good versus who just claims to be, the king of lips or the king of this or whatever, these self-proclaimed titles you hear. Yeah. But that's very hard to organize.
Absolutely. I mean, the only way around that to do it realistically is to have such a large sample size that even though they're different people that you're treating, it's your work still comes through.
Yeah, I think the consistency is the best way. I think that anyone choosing a practitioner can remotely come close to then saying, well, okay, I've seen enough of their work to then feel that I think they can repeat this for me.
Yeah, absolutely. But again, you can't tell that from before and afters. You can't tell that from interviews. You can't tell that when someone makes a video drawing on their face and talking about their knowledge, but not actually doing the treatment.
I feel it's harder than ever for a patient to choose a good practitioner. It's a private industry. It's profiteering and money-led. So practitioners sometimes can end up on the wrong side of ethics, chasing profits rather than chasing clinical outcomes. And then on top of that, you have these false terms given by filler companies sometimes to then kind of champion certain injectors because they are representing their brand or their product. And that product, like you might know by now, might not be the best, but they all claim to be the best because that's the only way they can make sales. And then you've got the other challenge is that every practitioner is private, so they want to be busy, so they'll have to then claim to be the best. And that's very hard to warrant. And then there's so many practitioners now that patients have infinite choices, and I see a lot of patients that end up in decision paralysis. They can't choose an injector because there's just so much and they don't want to make the wrong mistake. So I feel like compared to 10 years ago when I first started, where there wasn't as much injectors, there wasn't as much social media presence, there was not as much awareness of this, they almost just had to go with it, and then they either looked out, found a really good injector, or they didn't find the best one, they moved on to the next one. Whereas now they could end up in a C and repeatedly, one after the other, end up at the wrong one. And I see sometimes patients just have lost trust in aesthetic practitioners, and I'm trying to win them over because they feel that, am I just going to be another con artist?
Yeah, I think when people say, fillers make you look awful, and we'll talk about this in the podcast after, which we're going to record straight after this, there's no injectable that will make you look bad in terms of filler. It's improper use. That is the issue. Same with devices as well. So I see you've now got a filler for the under eye area. This is one of the thinnest fillers that we have. So we've done the anterior cheek, and we're now going to do the tear trough area. And we mentioned before the difference between true and false tear troughs. So again, that's the entry needle, and it's going to pretend it's the cannula to get it in the layer that he wants the cannula to go into. Nice and slow, nice and gentle.
Also, I need to get uncomfortable.
The area is slightly numb already from the previous filler.
It's the area where sometimes I find practitioners are most nervous treating patients here because the eyelid is so challenging and delicate, and patients nervous as it is, and then the practitioner's nervous, and this is the classic doom spiral where it occurs. So sometimes I see practitioners use the pilot needle. I mean, I'm using a 27 gauge. A lot of people use 25 or 22 sometimes, and that comes with a bigger pilot needle. And then what ends up happening is they end up making the area bleed so much just from the puncture. Then they don't wait for hemostasis, then they just put a blunt cannula in, and just suddenly they get hematoma. They get hemosiderin deposition, and then they get this browny staining of the skin. So honestly, it's an area where I would urge patients to really consider who they're visiting if they're going to have this done. You can pretty much get away with cheek filler from anyone, and there'll be a small difference between the world's best and the world's worst. But the difference in the eye is literally make or break. Yeah, so...
And I think just for those of you who may be new to some of the terminology that I'm going to use, when you talk about gauge, that means the diameter of the needle or the cannula. And if a number is higher, then it's a smaller gauge. Might not sound intuitive. So a 30 gauge is a smaller diameter needle or cannula than, say, a 21 gauge, because the number is higher. And when he said pilot needle, that's the entry needle that he used to make the entry hole for the cannula. And when he's talking about hemostasis in this context, he's saying that, you know, if you cause a bleed because the instrument was too big, you've got to wait for it to stop bleeding, you've got to wait for it to clot. And that's what we mean by hemostasis in this particular context. And if you get a hematoma, that's another way of saying like a sort of blood swelling in this area. I think hematomas can be, you know, easy to achieve here, unfortunately. But also, I think in the temple, if you're too harsh with a cannula, immediately, yeah. If you're treating this temple region and you're going just under the skin, not deep or interfascial, and you just be really, really harsh with your hands, yeah, I think hematomas there are very, very
common. Many veins in the area that you have to really respect the anatomy. And really the gauge of the cannula you're using in the area, which, I mean, it'd be good for you to explain to the audience about the theory of the larger cannula being safer, but that can equally then lead to disastrous outcomes, both cosmetically in terms of minor complications like hematomas being more frequent, but also if you do end up in a blood vessel with a large bore cannula, that's basically you then not just blocking the artery, you're filling the entire tree.
So that's a very good point. Now, some people will say that you should use a bigger cannula for safety reasons. And this is a lot of this is actually based on a paper, I think Cotofana 2019 or 2020 is the paper, where they basically looked at different cannulas and different cannula sizes. And they got a blood vessel and they rested the cannula on the blood vessel. And they thought, okay, well, how much pressure do we apply to actually pierce that blood vessel? And is it the same as the equivalent size needle? So when you got to a much finer gauge cannula, which I think was a 27 gauge, the needle goes through the vessel with a certain amount of ease. The cannula also went through with a certain amount of ease because it's so fine at that point, it acts like a needle. But here's the problem with that paper. At what point during this clinical procedure did we find a vessel and specifically rest it along that vessel?
Perpendicular to.
Yeah, exactly. At what point did we find a vessel and rest the cannula perpendicular onto that vessel to try and pierce it? We don't. So the clinical application of that paper is not as much as some people think. But because of that paper, people always sometimes say now, you've got to use a bigger cannula. You've got to use a 25 or 23 or 22 or 21 gauge. Now, Anne and I both are happy to use a 27 gauge because we're not resting it perpendicular on a vessel to try and pierce it. And if you use a bigger cannula, like a 22 gauge, like he's just said, then you have other issues which are going to be annoying you during the procedure, like it's a greater risk of swelling and trauma and things like that. So we personally prefer a 27 gauge. I do have exceptions, like if I'm working on the body, treating a large area, but for all intents and purposes for the face, I'm happy to use a 27 gauge the entire time. And I think you probably agree with me on all the things I've said.
And it's also the fact that how do you then handle that cannula? Now, if I had a 21 gauge cannula in my hand right now, because practitioners have this false sense of reassurance, it's a bigger cannula, therefore I'm safer. Yeah. They then handle it a bit more forcefully. They'll push harder. So the paper never said a 22 gauge can't get into a vessel. If you press hard enough, it will still go in. So people then were falsely led to believe that, well, as long as I don't use a 27, that then can get into a vessel, and I use a fatter one, and I can be rougher, then they actually end up still getting to the vessel, but with a more disastrous cannula, Whereas with this, I'm literally being feather light. I'm handling it with respect. I'm being very gentle. I'm being respectful to the planes. I'm not forcing it. I'm not shoving it around. And this is what you see when people are using a 22 gauge. They're shoving it, they're manhandling the patient. And I'm like, well, you're going to get in a vessel. And I've seen occlusions from practitioners who have ended up in the temple with a 22 gauge cannula, cannulating the deep temporal and then filling it. And the patient ending up with a bald patch up here because of hair loss. There was just no perfusion to the hair follicles over here. Similarly, the nasolabial fold, they went a 22 gauge, went all the way up, and they had a massive infraorbital frame, and just everything was occluded. It was such a nightmare to fix.
Yeah.
Because then you were basically trying not just to dissolve one small bolus. You're trying to dissolve an entire wedge of filler. It's very hard to do.
Yeah. Yeah, this is the thing, scientific papers, a lot of, members of the public even, I get it in comments, oh, this paper said this, but clinical practice is different to what's found in a paper in many, many contexts, and especially in aesthetics. You look at the way that Amrit's holding this syringe right now, just 2 fingers. If you were to try and pierce a vessel like they did in that paper, you would not you'd need to grip it a lot more, almost like a dart or a pen or a full hand grip. And so the translation of that paper, the application of that clinically is not there. It's a very good paper. It's a very interesting paper from an academic context, but in terms of clinical application, it doesn't match the way that we work. Look at how slow and gentle he is with that. Even if he was on a vessel, there's not enough force there to actually penetrate it. And so this is why, personally, I always recommend to people that I teach, if you're in the face, frankly, 27 gauge is all you need. You can get away with longer ones, shorter ones, depending on where you're treating. But I have never had a problem only using a 27 gauge. Never, ever, ever. And if you're treating the lips with the cannula, especially, if you use something really big, especially with a really big needle entry, then you're just going to get more swelling as well. It's really not, and you can't judge your work because you don't know whether it's filler or swelling that's made them look bigger, which is awful.
You can get filler dislocation much more easily with that larger cannula because it just is able to shove all the droplets you've done. Every time you go back in, you're pushing everything around and dislocating it quite easily.
The top tip there, if you're an injector, always go for a 27 gauge for the face. And according to us, how much units, how much volume have you done in that particular under eye area?
0.15 on the other side, and I've done 0.15 this side. So I've literally used 0.3 between the 2 eyes. Yeah.
So it's quite symmetrical, would you say?
Yeah, pretty much. Yeah. So I might do a bit more on that side. I might do a bit more here, but I'm going to carry on with everything else and then finish the eyes at the end.
Gotcha. So that's looking pretty good already, to be honest. He's looking in his 40s already, actually. We're already there.
So we're coming on to the buccal area, the more kind of what I would say the black hole area for Mark.
So I didn't move the camera with my foot then, did I?
Oh no, it's fine. Don't worry. This is all live. I'm very amateur on YouTube, as you can tell, but I like being amateur.
Right, so let's come to the buccal area here for Mark. So I'm just going to turn Mark all the way over this way. That's brilliant. So I can kind of really see the concavity at its deepest, and just pinching the skin. And I find that is a really good way to see where does it buckle, where does it fold. And naturally, Mark's already got some static grooves or lines in those areas anyway, but sometimes people don't have those. And it's not until you pinch together do you actually see where the deepest part of the trench is. So yeah, I can see there's a good depth over here. Good. Almost like a pond in the middle, and then another little stream on the side.
What's going through your mind right now when you decide where you're going to enter?
So I know that the best filler delivery will be when I've got the distal half of the kind of the second half, the further half. So I know that wherever it's deepest, I want the tip of the cannula to then sit in that area, but I want to enter far away. I could say, well, this is the deepest, so I'm going to enter right at that point, but I won't be able to get good projection outwards from there. So think of it almost like a seesaw. If I want to lift one area up, the far end of the seesaw will lift that up. So it means I need to enter a seesaw length away pretty much. So yeah, if this is the deepest part, and I can always under the skin curtain pole this a bit further and get the skin to kind of buckle and then end up a bit further than I want to. So I just want to make sure that I can get the tip of the cannula into that trench as accurate as possible, but also then avoiding this mesenteric area over here, where then if I have the filler track back and then pull together and create a bit of a jowl over the ears, that's not going to be good either. So I kind of want to respect that there's a mesenteric ligament here. If I can just go in front of the mesenteric ligament, I'll have a different compartment and I won't disrupt the two compartments.
So you're entering a little bit underneath the area that is going to fill, as you can see, hopefully in the close-up shot. As you do that, Karen, I'm just going to slightly shift to camera. There we go.
Okay, so I've made the little opening, and we're just gonna what I call fish hook under into the subcut plane. So coming into the skin, a bit of resistance, popping through into a subcut layer, which I'm now in. I know I'm in that layer because I can tent the skin up quite comfortably without seeing the grey of the cannula. I can move it side to side. I haven't gone through the smaz where then the cannula starts bending, and I know that if I'm moving the cannula one way but the tip is just curving, it means I've gone through the muscle, and the stiffness of the muscle is stopping the cannula then moving freely.
So when Amrit said he can't see the grey of the cannula, what he means by that is when you put the cannula in, I can't see that cannula right now. I can't see the colour of it because it's too deep. If you can see the colour of the cannula, it means you're so superficial, you're so shallow, you can still see it through the skin. At that point, it's really not the place to place filler. So he knows he's deeper than that, and he's in the superficial fat layer, which is the first fat layer underneath the skin. And it's the safe layer in this region, which is why we're doing this. And he's doing it in pretty much exactly the same technique as the other side. Nice and slow, gentle fanning, and he's not putting too much in one go because he doesn't want that sausage-like appearance. Can you tell me, does it feel symmetrical to the other side?
I'd say that side was deeper. This is not as deep. The groove was much more static and much more prominent on that side. It's quite soft on this side, other than this little smile on the edge of the nasolabial line here. So yeah, it's not going to need anywhere near as much on this side as it did on the other side.
Yeah, I think the other side was near as makes no difference, 2 mil.
Yeah.
So I suspect this is probably going to be max 1 to 1.5.
Agree. Yeah, probably just over 1, under 1.5. Yeah.
I think this is basically where people want the cheek fat removed from the inside of the mouth, and we're essentially doing the opposite of that here. We're putting fat back into this place because without it, that's what makes you have an aged appearance.
Especially if I augmented the cheek. I mean, augmenting the front of the cheek with a strong lateral cheek or outer cheek already, this area immediately looked much more hollower. And this is an area where there isn't really a course to teach this. Like all of the training academies that will teach the basic stuff will focus on outer cheek, bit of lip filler, nose to mouth marionette line, occasionally down to the chin, and then even tear trap is a stretch for a lot of those training academies to cover, or non-surgical rhino. Frown line filler is unheard of. Temple filler is pretty advanced for them. Buccal area, I've never come across a course. It was almost a self-taught procedure. And I mean, and the anatomy of this area is not that complex, like the eye, for example, but it's quite poorly done, poorly understood. It's a bit of a mystery for a lot of injectors, and something that then they just avoid doing altogether. And I see a lot of people using sculpture in this area as a volumizer, which I don't see.
It's a scar tissue generator, let's be honest.
Yeah, it's just you're literally causing a lot of inflammation, hoping that from the outcome of that inflammation will be to thicken and generate a lot of fibrosis, and that fibrotic tissue, which is then also a lot more vascular, will then somehow look plumper, but you're not delivering actual volume. You're trying to generate your body's own volume, which is just inflammation. So it might look plumper for a bit, but then when it's all settled down and all healed, you're going to be as gaunt as ever with just a lot of scar tissue inside the face.
Yeah, I completely agree. I mean, in terms of teaching of this area, you're right. What members of the public don't realize is the way people train in aesthetics and in doing these dermal fillers, they basically go on a course, and each course is like a different part of the face, and they build up these courses, and eventually they can do the full face. But even then, this particular area, the buccal fat pad, it's not, like Amrit said, it's not generally taught. I personally feel the only time people really learn this in any kind of depth is when they go on courses to learn how to do thread lifts, because you've got threads going across this area to try and pull everything up towards the temple. And so you've got to learn at this point that all the important nerves and things are a little bit deeper under the spas layer. And so it makes sense now why we put our filler and the threads above the spas layer to be nice and safe. So I think this is a brand new syringe when you entered this place, right? When you entered this particular region. And now looking at what I can see in Amrit's hand, he's probably used something like 0.7 mil so far, 0.6 or 0.7. And it can definitely take, I would say, the rest of the syringe and a little bit more of another syringe. But we'll see how it looks when he's finished.
Filling up so nicely. I'm kind of almost done, not far off finishing actually. Yeah, I'll finish the rest of the syringe off and I'll review and see. I might do the second entry from here, from the next syringe, and a little bit of the chin. And that second syringe might cover the remainder of these areas. Yeah, so we'll be one syringe less on this side than we did the other side.
And that's pretty normal to need more on one side than the other in order to look even.
I think that's the way we should be viewing it. A lot of injectors just say, well, if you took that much on that side, I need exactly the same on the other side. And then you end up just maintaining the asymmetry rather than correcting for it.
I think if you have asymmetry and you want symmetry, then the filler injection treatment plan must be asymmetrical in order to be the opposite of what you've got, essentially. And that's looking pretty good now. That was that a full syringe that we used?
Just under, yeah, 0.9.
0.9 mil. And when we use one syringe on the other side, we were probably, I would say, 50 to 60% in terms of everything looking nice and smooth. Whereas here, I would say we're probably sort of 75% of the way there.
Yeah, basically, yeah. I've literally got the finishing touches on the lower buccal section now that the upper's done, but in the chin shadow, and then basically just finishing off the two eyes, and then we're on to perioral.
I'm going to grab this tray here just to help out.
So it comes with a chin here.
So I'm just going to move to the pre-jowl area. He's going to point that needle towards the corner of the mouth, because that's where the cannula is going to go. So needle entry, want it in a couple of millimeters in the layer that the cannula is meant to go. And now the cannula is entering in the same way. And hopefully you can see that on the close-up. Possibly not, we'll see. There we go. Yep, we can. So now you're seeing a real life case, because Amrit's struggling to find the entry, and that's very normal. Probably half the time for most people. You have to spend a few seconds, 30 seconds at least, refinding the entry that you just made.
With the pores of the skin, and then you end up trying to find yourself questioning, is that pore or is that hair follicle entry point? Is that where I made the puncture, or is it next to that? Yeah. So which I'd rather be in that scenario than I've gone too deep and I've hit something and it's bled and I'm just waiting for it to stop bleeding before I can go back in, and it just bruises and swells up badly.
And then sometimes you can't find the entry at all, and you just end up scraping the cannula on the skin to find where it catches and goes in.
Which is equally fine, because it's not sharp or uncomfortable, the cannula on the surface of the skin. It's just a little, think of it like a little bit of a skin scratcher almost.
Yeah, it's a smooth, rounded end of that tube, so it just glides. It's really nothing to worry about. And this is looking good. From where I'm standing, this particular section is taking a little bit more filler than the other side. Does that feel that way to you?
Yeah, I'd say this is and it's actually also what Mark mentioned at the beginning, is this is his more downturned corner than the other side. So he even was able to see this. A lot of the time, patients can't see the same as what we see. Sometimes I pick up the brow asymmetry or the cheek asymmetry or the lip asymmetry in the patient, because it's my job to pick up these very, very minute differences, and they don't pick them up. Yeah. But when a patient's picked something up, then you know it's something that is really noticeable. Yeah.
Yeah, I think it's a difficult thing to talk about with a patient, because sometimes you'll notice an asymmetry and you've got to tell them because you need to treat it. And you also don't want the patient to think that you've put that there after treatment if that's the first time they've noticed it. But then if you tell them, are they going to become really self-conscious now? Are they going to start worrying about other things too much? It's a difficult thing to do. So we'll just say you can add a little bit more into that particular area.
Tiny bit more on this side, and I'll finish off the 0.2 I have in this syringe here. And then we've got one syringe to then start covering off the remainder of that, which we won't need all of that anyway. Yep. Finishing touches and then perioral.
It sounds good. So a little bit left in this pre-jowl area, which you should be able to see on the close-up now. Same entry point. You didn't need to make another one. It is going to stay open for long enough. And you can see the skin just puckering a little bit. He's just going through some of that connective tissue. And sometimes the downturning of the mouth, which was spoken about here, it's not just the area around the mouth you've got to look at. Sometimes that's also because of the laxity in the skin, the volume loss under the skin above that area, maybe in the anterior cheek, maybe in the lateral cheek. And as things sag over time, it sort of brings down the corner of the mouth with it. I appreciate this is a little bit difficult to see on camera, but it's the same as the other side. And we're just fanning this area in a sort of a V shape. And I think we're not that far away from being done. And by adding a little bit of filler into this area, we're actually providing a little bit of support for the mouth corner above it as well, which is going to help somewhat in downturning. But that doesn't mean you go overboard, because if you put loads of filler here to try and push the mouth corner back up, then you get another problem, which is that you put too much weight in that area and then it pulls it back down even further over time. So there is a fine balance of too little and too much to treat it. And again, that's why we've got to look at the whole face as one. If you treat the area above, like the cheek, then you're trying to pull things up as well as push from underneath as well. Amrit, would you say that area is over? It looks about done to me. I think that's good.
Yeah, so we are pretty much ready to just finish off this lower posterior buccal area now. And then we're on the home stretch.
So we're going to go into the buccal fat pad, the main area just kind of here that we were treating earlier, but we went upwards last time in this kind of motion. Now we're going to go across in a sort of cross-hatching technique, and this will allow us to basically make sure the first filler is nice and smooth with the action of the cannula again. Let me get that little tray for you. So exactly the same instrument, but we're facing a completely different direction, and the amount he pushes it into the skin will be about the same, because a little bit sensitive there. Because he's still going to be in the same layer. He's still going to be in the superficial fat layer, which is the first fat layer under the skin. So he's going to, again, resting on the face, angle down, and then flatten off. There we go, once he's in the correct layer. And if you can, on the close-up, see if you can find any skin puckering that then releases as he pushes forward. And you see where he went left and right? If he was in a blood vessel, he wouldn't have been able to go left and right. And you can see the puckering there, that's then releasing. So it was a safety check, which is why he was going left and right. And then the skin puckering and releasing, that's him just going through some of that connective tissue. And you'll notice that even when he was going vertically, that was happening. So these connective tissues, you can reach them from any angle because they are happening in multiple directions. And I suspect he's not going to need anywhere near the full syringe for this because it was mostly done already. And you know what, standing where I'm standing right now, looking at the amount of volume we've replaced, that's a phenomenal result already. We haven't even done the finishing touches yet. And when we do finishing touches, I think, sometimes I will, if I think patient needs 5 syringes, 5 mil, I will say with finishing touches, it might be 6. And I'll use that final syringe just to add little tweaks here and there, maybe where one area of the face meets another and there's a little bit of a dent or a little bit of a dimple. I'll just use it for something like that. I don't know how many syringes this is now. This is probably around number 10, I'm going to guess. 10 or 11?
Yeah, so we've opened up 11. This is number 10, which we have the majority of this left. And we've still got the majority of the under eye syringe left yet. So we are 8 full syringes in and about half.
And that's actually not a lot in a case like this. That's we over time, after a couple of months, we could potentially come back and add a little bit more in multiple areas.
It's one of those where when you quantify it into teaspoons, which a lot of lay people understand a bit more, 5 syringes is about a teaspoon. So which is still not a lot of volume if you know.
Teaspoon or tablespoon?
Tablespoon. Yeah. So we're literally just over a tablespoon, but not even at 2. And that's then being distributed all the way from as high as a temple to the anterior cheek, piriform, buccal area, chin, prejowl, posterior jawline angle, and somewhere we're now going to the perioral areas. It's basically a full facial rejuvenation with not that much volume. I've seen people put 8 mils into just the chin and jawline, and they've overdone it, and then they're relying on the bad filler rheology to then just give a very temporary result, which then as it heals and settles, it just becomes so soft and undetectable. The patient's left wondering, well, I bought 8 syringes, where did that go? So sometimes I have patients who have never had anything done who are shocked by the sound of even 5. Like 5 is about an average full face I'll do. I very rarely go more than 8, or I've never really done more than 10. It's just you'll basically be looking at someone with severe atrophy that needs that level of volume.
Someone sort of at least 50, 60 plus.
Yeah, 50, 60 plus who's underweight, low BMI, or has had like severe medical problems over their lifetime where then they've lost all of the facial volume and they've really atrophied. I can only really think of a couple of cases where I had to go to about 15, 16 mils, which was because the patient had been in hospital for about a year and a half recovering from a major stroke, and they had some dramatic volume loss in their face. But typically even the weight loss majority Ozempic patients, they kind of come up to about 8 sometimes now, because they tend to have lost quite a lot.
I mean, patients who I've treated who were on weight loss medications and who have lost serious amounts of weight, I'm talking 50 kilos plus, I have done over 10 mils. for them, because that's a severe weight loss.
Lost it very aggressively and rapidly, and it's not being controlled or managed properly, and they've lost bone and muscle and fat pads. Then you're basically rebuilding a face, not just revolumizing the face. Yeah,
you're giving it pretty much everything back at that point. And the problem with those patients, if you're someone that's had a severe weight loss, it's very difficult to actually do this kind of treatment as you're still losing weight, because your face is still changing. And my advice,
probably 2 away a week that are halfway through their journey. They still got another 6 months to go, and they're like, well, can you just top me up to get through the next 6 months? I'm like, no, if I feel you right now, I'll be dissolving that, or I won't know what it'll look like in the rest of your weight loss. I need to then see you at your end.
What people don't realize is, yes, you are losing visible volume, but you're changing the tension, for example, in connective tissue. It's not just the fat that's being lost, it's everything that's connected to the fat is now changing as well, even if it's not being lost. So if things are more saggy, then that means the filler could potentially become more saggy if you add it too early. So my advice to patients who are, have Ozempic faces, as I think the news has now called it, the media has now called it, is finish the journey that you're on, finish all that medication, tighten the skin with something like an ultra clear laser or something along those lines, get it where you're happy, and then replace the volume afterwards. And you're doing the same entry point here?
Same entry point, just a little bit of finishing touches here. Now that I've had a look at the other side and compared, there's just a little bit in the deep cheek fat that I can kind of go in and finish off from this, and just use what's left here before we tidy up the eyes and then move on to the perioral area.
Do you not find this area easier with the patient looking left, or are you happy with this?
Oh no, this is pretty good, because I just want to get into this divot over here. So I just want to then see, and I want to be as deep as I can. Well, that's it, just for this last little bit. It's me then just using the cannula on the entry to get to where we could have with the needle. It's just using advantage of what we've already opened up and made to then just reach that area and finish it off. There we go. Okay, good.
Looking very good. So as we come towards the end, how are you feeling about the under eye area? Do you think you'll still go back and do some, or are you happy to leave it as it is?
Just do a very small amount more blending. So this side I'm pretty happy with. I'll sit him up and have a look how that's looking. This side, there's just a little bit more I could do to just hide the under eye false tear trough bag a little bit more. This side I can kind of see it looking prominent without the prolapse. As he lies down, the prolapse kind of, the gravity sinks into the...
Always looks better when they lie back, right?
Yeah. And then if I sit him forwards, the bag will come out, which will blend the two together. But it's one of those where you do it, you have to then sit them under gravity to have a look at how it's changed, and then you go in and refine it. So that's what I'm going to do on the other side.
Some of you on my channel, you may have seen not that long ago, I made one of my sort of big guides specifically on the under eye area. And one of the things I talked about in the under eye area in that video was volume. Not enough, too much, or bad position. And I mentioned that one thing to look at is the difference between a true and a false tear trough. And today you've seen a false tear trough. This is literally what it is. So I'm just going to go back into the other side, and the entry point would have closed from before. So it's going to have to re-enter with that pilot entry needle, which is the technical term for it. Do you want Mark to look right, or are you happy? You're happy with that? So he's going to use that needle based on the length of the cannula. So this area is going to be a little bit more sensitive because we stopped putting filler in there a little while ago. So the anesthetic from the filler probably has worn away, or worn off, I should say, a little bit. So now he's going to go with this cannula. He's going to go with a big angle, and then he'll flatten off.
And this is where I found Mark's connective tissue was really tough, which is good for Mark. The retaining ligaments are very thick and healthy and holding the structures to the bone. But it means that I get a lot of resistance, which then for more novice injectors is quite unnerving. They almost feel like that's too much resistance to push through. So then they'll just dilly-dally around and end up probably not going to where they need to go. Whereas actually it's just about maintaining persistence and knowing that that's a natural resistance, and I know the anatomy of this area, so I've just got to be patient until I can find a smooth path through, but it will take quite a lot of pressure just to get that pop.
And you will have seen that on the close-up, hopefully. So that's actually, I said something very interestingly. I said Mark's got quite strong connective tissue here, and you can tell that by the amount of effort it took to actually break through it. However, from Mark's perspective, I suspect that's one of the reasons he doesn't have a huge amount of skin laxity. That's one of the reasons, actually, even though he's lost fat volume in his face, he did not have jowls. because I think the retaining ligaments, the true retaining ligaments, which go all the way from as deep as possible into the skin, they have enough strength to keep everything held up, which, people pay a lot of money to get things like that, but he's got that naturally. It's just a fat that he's lost, which makes it a much easier case to treat.
With that, it's an interesting one because so Mark mentioned, and even at the beginning of the video when he pulled the back of his scalp back and was able to kind of get that tension, the question of do I need a facelift, is that what a facelift can achieve? But they actually divide through the retaining ligaments to kind of give you that traction, and they just rely on the scars behind the ears or in front of the ears to suture everything together, which then you're then removing the excess skin laxity, but then you have no retaining ligaments tethering the skin to the bone anymore, which means you can age much more quickly or lax wise and much more noticeably after that. So I always say to patients, it's best to try to put off something as interventional as that for as long as you can. And are there things they can do in their lifestyle to improve those connective tissues?
Good question. So let me just translate a little bit of what you said. So what I'm saying is when you have a facelift, you have an incision that usually starts behind the ear, goes up all the way across, and then behind the other ear, and they use that to pull everything up and stitch it. But in the process of that procedure, depending on the surgeon and the technique, and there are lots of different types of facelifts, by the way, it's not that simple, but sometimes they actually go after these retaining ligaments. And when you do that, you can age a little bit worse after the facelift than before, which then gives you another problem, which is a tricky thing to try and treat, which is why there are devices like the ultra clear laser now, which I think if you start early enough and you do things like that, it can put off the need for a facelift in certain cases. But then the question he had for me was, is there anything people can do to try and strengthen these ligaments? Well, theoretically, yes. One of the most important things is diet, because if we have enough branched chain amino acids in our diet from animal sources as well, then what that means is that's going to trigger the physiological growth. That's going to be sensed by something called mTOR. And when that happens in skin, what happens is we produce all the different collagen types and all the connective tissues. And same with chondrocytes, say in cartilage, to produce good amount of cartilage, etc. So we can do that in a global context. In a local context, theoretically we can, but there's not many products out there in the market that can do that right now. Yeah. And unfortunately, it's not available in the aesthetics market, which is a shame, because it makes perfect sense to try and strengthen connecting ligaments in the face, to try and maintain the strength of everything being held up. So how do you feel about that under eye? I think that looks fantastic now, yes? Yeah. Oh, good. So what have we got to do left now? We're just going to clean the skin?
Just a little bit of perioral work I wanted to do for Mark. He requested it. He's got a few, sometimes they're called smoker's lines or perioral lines, barcode lines, but these kind of bicycle spokes around the mouth over here, more in the upper lip, which is where he's lost a bit more volume than in the lower lip. So I just wanted to kind of go in and just do a little bit of cannula work just to try to tidy that up with a soft filler. Nothing to give him a lip enhancement, nothing to go for dramatic volume, just to really smooth those out a little bit. Yeah.
So these barcode lines, this is not an easy area to treat, because what Amrit said he's going to do is going to take a cannula, and that cannula is going to just gently brush the filler very, very smoothly, like a thin layer of paint. The problem that I think a lot of novice injectors make is they think they can treat this area like they're volumizing any part of the face. And what happens then is you get this massive sort of inflation above and below the lip, like I've mentioned this before, like Homer Simpson. And they're doing that because they don't understand that you're really using filler to traditionally, conventionally volumize. What you're trying to do is just add a little bit of tiny padding, and that's it. You're not trying to make anything look overall bigger. And I've seen other people who use a technique with a needle, and they actually chase the lines individually, which can work. It's very time sensitive, can be a bit more sensitive for the patient as well. It's not easy to do. Absolutely.
So two small scratches left, Mark. We'll do one side first and the other side. Do a big breath here. It's always a bit sensitive over here.
So he's going to do a very superficial entry in this region, because a cannula needs to stay superficial or very shallow. In that side Amrit's done, it's probably not going to be as sensitive as Mark's left, because the side he's entering on, there's filler in that piriform fossa, which is the base around the nose, and there's anesthetic there. That will allow a little bit of loss of sensation from the lip. So it's not going to be as bad as the other side, I think. But again, a very superficial. And as soon as he's in that right place, he's going to flatten off.
Good breath.
Yep.
Pressure, see, so a bit uncomfortable as we just get the cannula along.
Yep. Would it be possible, Amrit, to get Mark to look a little bit left? Is that okay for you?
This is, oh yeah, we can do actually. Yeah, it's fine for me.
Would you mind turning left, Mark? There we go. That's just so that people can see on camera what we're doing. That's good.
So I'm just running, I don't want to run in the lip. So I could just go a little bit lower and end up in the lip tissue, which is fine. I can fill lips that way using a cannula for very subtle natural rejuvenation of you have the classic M shape upper lip pattern where they have the pockets in the middle of the upper lip over here. Then that works great. But here I want to stay in the outside of the lip tissue, superficial, just to go into the subcut plane here. And then we're almost into the middle near the philtrum columns. And then just add a little bit of volume. Like Ab said, just small amounts. I'm using a very soft filler. The goal is not to just overly volumize this area and create what I call a shelf. It's just to soften those lines. Think of it almost as little crinkles in a pillow. And if you just put a little bit of a firmer or a bigger pillow in behind the pillowcase just sits more flush or stretched out. Well, that's what we want to do. You just want to stretch these lines out a little bit, but not grow anything in size.
And that's why we're using the very, very soft filler. This is the same filler that we used under the eye as well. If you use anything thicker than that in this region, the filler's going to take a shape. And it's going to be the shape that you put it in. Whereas if you use a very, very soft filler, it's going to be the shape of the anatomical space that you put it in, which is what you want. And if, Amrit was a little bit lower, not only would he be in the lip, actually he would create a connection between the red part of the lip, the body of the lip, and outside, and the filler could then track through that connection and come back out. That's a lot of the reason why sometimes you do see moustaches above lips because of the entry point above the lip. We'll just turn you around, not the other way. If you could turn to the right, that's it. Perfect. Is that all right for you, Alex?
That's great. Yeah. Before we do that, if I just turn Mark in the middle, and Mark, if you just make a little bit of a pout with your lips. There we go.
Yeah, you should be. Hopefully you can see that and can layer the difference.
Even before he's had time to heal and do his job, you can see there's a lot more parallel lines on this side. But yeah, we'll turn you the opposite direction, Mark. We're just going to finish this off. Last little pinch, last injection. You've done amazing. And we've done, lost count of how
a lot.
The same treatment.
Yeah.
But we haven't really had a major bleed at all, which is great.
Mm.
So yeah, all wins for 30 gauge and needles and 27 gauge cannulas. Big breath here, Mark. That's it. That's it. Well done. There we go. Yeah, we knew it was going to be a bit more sensible this side because of the anesthetic.
So exactly the same technique. He's going to find the entry point first, which is not as easy as it sounds. As soon as he's in, he's going to flatten off and try and maintain what Amrit called previously the subcut plane. So that stands for subcutaneous, so just under the skin. Basically, he wants to be under the skin, but as high or as superficial as he can without being in the skin. And this is the advantage of a cannula. You'll never be in the skin. A needle can get you in the skin, and in some places sometimes you want that, like in skin rejuvenation treatments. But a cannula will never be in the skin. It's always going to be under the skin. And you take advantage of that, when it comes to, say, volume, for instance. So this is a little bit sensitive, as we expected. But what Amrit is going to do is going to start releasing the fur with his thumb on the plunger. And that's going to release some of the anesthetic into the area. So as he treats the area, it becomes more and more comfortable. It becomes more and more numb to an extent. And you should hopefully be able to see that on the other side, there's no sort of increase in the lip size at all. It's just a slightly smooth area. I'll do. That's a bit bad. There we go. It's a little bit, very sensitive area there. And look at the difference between this and the under eye. The under eye, which looks scary, was completely comfortable, and we were having a conversation with Mark at the time. Whereas here, it's very far away, and yet it's more sensitive. So what looks scary doesn't necessarily mean that it's more risky or it's more dangerous. And this is where anatomy comes in, and you have to know your nerves. And I think we can see there everything is looking nice and smooth. How much volume did you use there, Amrit, per side, roughly?
0.2. Yeah, 0.2 ml per side, roughly, or just under. Yeah, not much at all.
Very, very small one. That sounds about right.
Perfect. All the needles are done for Mark, which he's done phenomenal with, especially the most uncomfortable part, which is always ironic. People always assume it's going to be the eyelids, and surprisingly, that's the bit at the end where they say that was the most comfortable part or the relaxing part. And the bony injections aren't too terrible. They're okay. They just more crackly, crunchy, bit of pressure. But the perioral area is a very delicate and sensitive area, which is why I always say, you know, you get a cold sore on your lip, you know it's there. It's really uncomfortable, really sore. It's just such a nerve-rich area. It's an innervated area. It's an area where, because there's so much bugs and bacteria inside our mouth, we need to know when there's a crack or an injury to the mouth so that it can kind of then really heal.
Yeah, and at the end of the day, we taste with our lips as well. And that's, you know, if we don't eat, we're dead. So we find a lot of things in the mouth, even inside the mouth. The vasculature is vast, and the ability to heal cuts in our mouth is incredibly huge compared to everywhere else. If you cut your skin, you're just going to get a scar. But if you cut your cheek by biting into it, by a day or two, it's pretty much back to normal. There's no scar. It's just original tissue. So how do you feel we're done now here? It's just a case of cleaning the skin and then sitting up? Yep. And what I'm going to do is just step off camera for a second, and I'm going to grab my phone here. And as Mark sits up, I'm going to actually video on my phone as well. And then hopefully my editing team, John or Jamie, whoever's watching this, after Mark sets up, we can actually overlay this second video onto the screen. So Mark, if you want to sit yourself up, and then probably feel like you're falling asleep there.
Yeah.
So that's it. So I'm gonna start from the side.
Still
numb. Yeah. There we go. So we're coming all the way around, looking much better. Look at all that volume that we've replaced. That's fantastic. Amrit, how do you feel?
Good. By the same art piece, right? I'm gonna do how I did the little touch up on the left eye at the end.
Yep.
The right eye we've just done the original one, so I'm gonna do a little touch up on the right eye.
Okay. Yeah. Make it as even as possible. Yeah. So you can lie yourself back, Mark.
another member.
Yeah. We are exceptional just
Yeah, which is, to be fair, the comfortable bit. It's not too bad. It's on the side we've been working on too, so it should be pretty nummy and stuff.
So we're just going to add what Amrit is saying, is going to add a little bit more just onto this section here, so it matches this side. And it's not surprising it needs a bit more, because we did volume more on Mark's left than Mark's right. So we'll use the same filler. I think there's probably a little bit left in the syringe. Is there? Yeah. Yeah. So we can do that very easily. So
sit Mark forward briefly, just because it's something that is more visible when you're sitting on with gravity. I can see it here clearly. There we go. So we can kind of really see that little transition where we want to go. There's almost like a little tiny gully. I just want to go into this gully here. I can see that transition quite clearly over here. But when he lies down, it disappears because of fat prolapse above it, or the false tear trough disappears because of gravity. So it's interesting. A lot of patients who have the puffy under eyes have been turned down and said, you can't have under eye filler, which is true. Like, you technically shouldn't have filler in the eyelid. It'll make it worse. But they can fix the eye bags with filler. It's just the practitioner says you can't because they don't know how to do it. So they will just lie to the patient and say, well, you can't have that, you need surgery. But it can be quite nicely done, like you can see on the other eye that we've done. So if I get Mark to open his eyes and chin down a little bit, that's kind of the most gravitationally dependent version we can get. And we can kind of see there's a little bit more volume to do in that bit there. But yeah, nice and easy to do.
Mark. And I think as Mark sets up, we can see the obvious improvement from the start of the appointment.
Yeah.
But actually, if he came back a year later, we could probably do the same volume again and get even more of an improvement.
It is basically that. It's about a year later, either to maintain what we achieved, we do roughly half or less.
Yeah, same.
But to then try to get it another step further, make them look even fresher, which is where you kind of see some individuals that have been having filler for years, they just kind of look like vampires. They don't seem to aging. It just holds so good. So then you can kind of keep pushing the boundaries and making them look younger and younger over time. But
Could pencil that in.
yeah, that's it. So last little bit then, Mark, I'm just going to finish off this eye here. I'm just going to go in at a slightly different approach angle for Mark, because you can see the majority of the volume is a bit more on the outer eye now, and there's not much of the inner eye, so we can kind of use a new entry over here. So if I just turn Mark a little bit to the side, just like that, brilliant. We'll make a very small little puncture on the side here. So if we do a nice deep breath here, Mark, sit, small scratch. There we go. Just being still super patient, We don't want to get this close to the end and then finish with a big bruise. There we are.
So again, he's done a very, very shallow entry with that entry needle because he needs to be in a very, very superficial layer. And again, he's going to point the needle down. He's got quite a big angle to the skin there. And as soon as he's in the right layer, you'll notice him drop that syringe down and then try to flatten everything off. But again, what makes it a little bit difficult for the practitioner in this case is the fact that Mark's got really quite good quality, strong connective tissue. But then if it's a novice injector, what they might do is really force that cannula to get through, and that's when you get hematomas and swellings and bruisings and all these kind of things. So the key, if you're an injector watching this and you're finding it difficult to get through, is to have patience. If you have patience, you're maybe twisting the cannula, maybe going back and forth, finding different angles nice and gently, you'll still get through even thicker connective tissue. And he's going to very, very gently drop his, or push his thumb through to get a very, very small amount. And would you say that this entry was a little bit easier to get into the right position compared to the previous one?
Absolutely. I think possibly because I've made a little bit of a tunnel already in this area, there's already a potential space opened up. It's been a bit easier. But having gone through it and had that little bit of a feel of Mark's anatomy now, I kind of know the rough pressure I need to get through his ligaments. So it's a case of first being very low pressure and then ramping up the pressure based on what they need. But my non-injecting hand, or the one I put all my weight onto for the patient to distract them from what's going on around it, but that is just torting the skin as firmly as I can. It makes it much easier for the cannula to then make tract through. When the skin is lax, the cannula ends up just pushing the skin around.
Even needles, actually, I think when you're trying to enter the skin with the needle, especially a very, very fine needle, like a invisible needle, 34 gauge, 35 gauge, when people have their hand too far away from the needle entry point, there's no tension. So instead of penetrating the skin, it rests on the skin and then pushes it in. And then when it does break through, too much of it has gone through and you just lost the depth that you're trying to reach in the first place. So look at Amrit's right hand really pushing that skin down, job number 1, so the cannula can go in easier. And job number 2, his left hand is using his right hand as a rest, just like we said earlier, to keep everything nice and still. If you see an injector with a needle is hovering like this, I would say they're very amateur and they're very novice. Keeping it nice and still is something I think comes naturally to dentists because we have drills in our hand. But not necessarily to other fields, but he's doing that perfectly here. And actually just looking at the volumization, I think that's looking very, very similar to the other side now. And I don't think you've used a great deal of volume, to be honest.
No, 0.05, not even 0.1, half of that.
0.05.
The interesting thing is also with the tension, Abs, I was saying, is when the skin's this under tension, this retracted, if I do over inject a little micro bump, if I let go of the skin, it's gone. I saw into the future of what was going to become a very big bump without tension. So it reminds you how to keep the pressure so low, because you were stretching the skin. It's easier to see what you're placing under it when it's taut. So that for me is another way to prevent lumps and bumps and other filler complications, which from a patient's perspective, they often get so nervous about either overfilling or the more scary complications, blood vessel related stuff, that they almost forget that there are other minor complications that actually are more common, especially with eyes, such as cosmetic lumps and bumps and tyndall, which they end up, getting in and then having to have it dissolved and yo-yoing between filler and dissolver and filler and dissolver. So it's probably the area I see the most corrective work needing to be done. Because there's just such poor training on the false and true tear trough approach. Everyone just gets taught 2 pops into the sooth and fill, which is fine for a very small select number of patients, but you can't apply that template to everyone. So you're basically defining the template as and how their anatomy requires it. But yeah, you can see this is probably, even though we put 0.05 in, it's been the slowest, amount of filler per unit time that we've done today.
Yeah, speed I think is very, very key for certain areas. If you're going deep onto the bone, I don't think it makes much of a difference, unless you're using maybe something like Radius, in which case you want to limit how much you put in each position in case you are in a blood vessel, because you can't really dissolve that in the way that you dissolve filler. But here, you got to be very, very slow so the filler finds its place, goes into the deepest bit, and also just so you don't get the hematoma and the swelling and things. And I think that's looking pretty much done to me.
I've done the inner section completely now. I've just got this last little outer tiny bit to do on the lateral eye, and that's it. Then we're done. And there's no more after this, Mark. I promise you. This is it done. And this is all my OCD and fussiness out of the way, which I think is important in my job, you know?
Yeah, absolutely. I think if you don't have that attention to detail, this is not the right job for you. You've got to have a little bit of pedanticness about you, a little bit of OCD. Looking good, looking good. So in total, I think we have used ballpark figure around 11 mils, roughly speaking. And this is a patient which, you know, if we look at some of these areas, I wouldn't say it's exactly the same in terms of volume as when maybe he was 25 or 30. And there's still room to go. And so people that hear, you know, 11 mils or 11 syringes, they think, wow, that's too much. Actually, no, it's relative to the patient. If they've had 12 milliliters of volume loss, then 12 syringes is absolutely fine, assuming it's placed in exactly that place. So you've always got to look at the patient and then judge, is it too much filler, is it not? And I don't think, you know, Mark looks like he's had tons of filler.
No,
It looks like that's just his face. Yeah, it's just the way he is.
you walk outside today and no one would, you know, even people he knows or a stranger on the road wouldn't be able to just tell he's had, you know, 11 syringes of filler into all areas of his face and 100 odd injections and cannula work, you know?
And I think part of that is because of, number one, the needle choice being very, very fine, and 30 gauge, and number two, the cannula choice, that being a 27 gauge. And I know there are people that doubt that, but, you know, this is real time. This is done in front of you, so you can see how good this is for making sure that you don't get bruising, you don't get swelling. I remember when I was told to use a 25 gauge cannula for everything. And very quickly, I fell out of that, yeah.
That was what I was taught as well. And I was taught to use very different, thicker fillers in this area, Juvenile namely, which, yeah, is a lesson learnt the hard way. But yeah.
I mean, Juvenile for me is I'll probably bleep that word, but it's one of, if not the worst fillers, in my opinion, that has ever been made. My advice to you guys, never, ever, ever get that in your face. And I actually did a video talking about hyaluronic acid and dermal fillers. I'll see if I can link it in the description here. It's 5 hours. It's incredibly deep and detailed. And I've always said I think that's the deepest education on the topic anywhere in the world. And if you find one that's deeper, please comment below and I'll correct myself. But I'll link that down there and you guys can have a look. And you understand why I don't use that filler specifically, and I have my personal preferences. In all honesty, nowadays, I think there are a lot of fillers that aren't terrible, not necessarily perfect. In fact, there's no perfect filler. But I think nowadays, as long as you have a reasonable filler, it's the injector that makes more of a difference than the filler itself. And that's why I wanted to come and do this with Amrit, because I've seen him inject. You know, if I ever need filler, I'm sure I'll give you a call at some point. Probably within the next 5 years, I'll have my first injection, and we'll see if I'm a bit of a crybaby on the table. Mark, how did that feel overall in terms of pain? Obviously, it was sensitive around the lip, but in terms of what you expected it to be like, how was it?
Absolutely fine. Painless. 1 or 2 injections, but painless, really.
And how does it feel with that volume in your face? Because some people think, you know, 11 mils is a lot. You must feel inflated. Be honest about how it feels right now.
It doesn't feel any different, except for the numbness. And
even the numbness is right now is probably only on one side, right? Because we finished the left a while ago.
yeah, I mean, you know, the numbing cream, and now the we're not bruising, but from the injections, and of course with the retainers in, it's hard to speak as well. Jaws all.
I mean, the fact that you feel fine says a lot from the 11 mils. Sit yourself up, and we'll have a little look.
Camera actually, he can kind of like find his way through with cameras to the enigma and can maybe see, we can almost share his reaction or response to seeing the.
Do you want to get your sister?
Yeah.
Yeah.